ค่ะ
Entendi. Existem exercícios
Good morning. We are all welcome to this Saturday's workshop. I can see our facilitator has joined, and we welcome everyone for joining. And I wish us a happy deliberations. You are welcome, sir, and I think we can start. Thank you.
I can leave the key, right?
Good morning, everyone. I must say that I feel so honored and delighted to be with us again today on this continued professional development program under the Ray Medical Rehabilitation Institute. My prayer is that each and every one of us will make remarkable progress in this, our chosen career. I want to appreciate our commitment to professional development. It is a time when so many, based on economic situation, would rather shy away from investing on such. But our commitment has made it that we are here. Thank you very much. I want to believe that we must all have seen the advert that was sent out for this program, whereby we may not need to waste time going through, the kind of introduction that, we will have done. But because of a few who might not have actually seen it, maybe I should still do that. So once again, we are welcome. And the theme of the workshop is enhancing respiratory care through traditional and modern chest physiotherapy techniques. And it's a one-day program. And we have expected goals for this workshop in terms of workshop objectives. Said that by the end of this workshop, participants should be able to understand certain things, which include the foundational principles of chest physiotherapy, the physiology of airway clearance, the pathophysiology of secretion retention, the indications, contraindications, and evidence base for each chest physiotherapy technique. And then also be able to identify and differentiate between the traditional techniques and the modern or instrumented techniques. Participants should also have become familiar with the use of common airway clearance devices, as well as the mechanisms of common airway clearance devices, that is the mechanism by which they work, and then be able to apply critical thinking to select appropriate airway clearance technique for adult and pediatric patients in different clinical scenarios. And in fact, that is one of the sessions that we are going to have, which is going to be case-based, where we'll be looking at some cases, and then we will all interact to profile the best line of management for those hypothetical patients. It is also expected that at the end of the workshop, participants will be able to demonstrate competence in manual chest physiotherapy techniques. Ideally, we had thought that we would have a substantial proportion of the participants registering for physical attendance, and then we will have been able to incorporate hands-on. But unfortunately, we didn't have such. And to compensate for that, we have made sure that there are a lot of illustrations and videos that have been incorporated into this workshop. It is also expected that participants will be able to integrate assessment skills with treatment strategies in order to evaluate the effectiveness of their intervention, and then be able to adjust intervention based on patients' response to what they are doing, and also be able to enhance patient education and empowerment by equipping both the patients as well as their caregivers with techniques, for home-based chest physiotherapy. And we have this program, which I believe we are not too far from now, because the introduction or outline of the workshop is expected to last between 10 and 10:15. And I think we should be about 10:20 or thereabout now. So we are not too far behind our schedule. And we believe that in the course of the program, we'll be able to make up and still fall in line with our timing. We are going to have 7 sessions. One of the sessions I've merged in a single presentation, and that's going to be sessions 4 and 5. I have a single presentation, but I will be using the 2 periods for that particular presentation. So the first presentation is going to be on the principles of airway clearance. And then the second presentation, we are going to look at the traditional manual techniques, some of them, and then we'll have a short break. And after that short break, we proceed to look at the remaining traditional manual techniques. And then session 4, we'll begin to look at the modern instrumented techniques. That period will not be sufficient to look at all of them. So it will be interrupted by a lunch break, which will last just about half an hour. And then after the lunch break, we continue with the instrumented techniques, part 2, in session 5. And after then, we'll move on to session 6, which is going to be interactive, where we have clinical case-based application. We'll be looking at 3 cases, and then we will all be interacting to profile the best line of management for those hypothetical patients. And of course, the session 7, which is the last and the final one for the day, we'll be looking at actually integrating all these things that we will have learned, or we have learned before, and we are only refreshing our memories into our daily clinical practice, and then be able to appropriately document what we are doing, because one of the challenges we have observed in this our region here is that record keeping of our management is not ideal. It leaves a lot to be desired. And so when it comes to bringing forth evidence for what we have been doing, we become incapacitated. Then some of our younger ones, when they want to do research work and they need to go into records to do review, the records that are available are either incomplete or not usable to them for research. So we are going to discuss it, what we really need to document, so that whatever documents we have kept will be usable by so many other people, and will also be usable to advance the practice of cardiorespiratory physiotherapy, not only in Nigeria, but wherever we find ourselves. And then we believe that shortly before 5 o'clock, we should round up. So that, in a nutshell, that's the program we are going to run. So let me now come back to the first session. Again, we are welcome. So the first session is dealing with principles of airway clearance. Principles of airway clearance. And this is very important, so that when we have to employ procedures under this description, we will know why we are doing what we are doing and why we are doing it the way we are doing it, because it will be based on the principles. It is believed or expected that at the end of this first session, that is this particular presentation, participants will be able to explain the physiological basis for airway clearance and not belong to the group that carry out airway clearance just for the sake of it and routinely, rather than applying basic physiological principles to decide whether it is necessary or not, and if it is necessary, which one in particular will be most appropriate. They will also be able to identify the indications and contraindications for chest physiotherapy procedures. And then they will be able to understand the goals and the principles that guide airway clearance techniques. Now, in order to have a very good grasp of this, it is important that we briefly look at the functional anatomy of the respiratory system. We will not be going into full review, but rather touching on the aspect that relates to the airway that we want to clear. So when we look at the respiratory system, there are actually 4 processes that are summarized as respiration. We have ventilation, we have external respiration, we have gas transport, we have internal respiration. Ventilation has to do with the movement of air in and out of the lungs, exchanging respiratory gases between the alveoli and the environment. And for the air to get into the alveoli and also to come out of the alveoli and be returned to the atmosphere, the air must go through certain routes, certain passageway. And these are the things that constitute the airway. Now, this airway has several segments or portions. And in terms of sequence, from outside to the inside, the airway starts with the nose and the nasal cavities, where we have some hair follicles that are responsible for filtering the air that we are inhaling, such that particles larger than certain size are filtered by the air follicles and not taken into the lungs to damage the delicate lung tissue. In the nasal cavity, we also have these cartilaginous scroll-like structures that are referred to as the turbinates or the conchae. And there are three. And they throw the nasal passage into three narrower or smaller meatus's. And by virtue of this, they are able to cause the air that was coming in a laminar fashion to be thrown into turbulence. And we know the importance of this turbulence, such that every particle of air that is being inhaled will then have opportunity to come in contact with the lining of the nasal cavity. The lining is lined by mucosal cells that is highly vascularized. So in coming in contact with this membrane, the air gains some additional water vapor beyond that which is inherent in it as it is coming from the atmosphere. It also gets warmed towards the body temperature, so that the air that goes into the lungs does not damage the lung tissue because it is harsh and cold. So now we can begin to see some form of secretion, even beginning from the nasal cavity in terms of mucus. Now, beyond the nose, we have the pharynx, we have the larynx, and then we have the trachea. The trachea consists of these C cartilaginous rings and with a smooth muscle cell that link them at the open ends of the C. And these are the bronchial smooth muscle cells that are responsible for changing or varying the diameter of the trachea. And when they contract, we talk about bronchoconstriction. And when they relax, we'll talk about bronchodilatation. Now, at this upper respiratory tract also, we have particular types of epithelial cells that are also secretory. These cells are referred to as the pseudostratified ciliated columnar epithelium. And the fact that they are columnar cells means that they are secretory in function. And then, of course, being ciliated talks about the presence of special structures, the cilia, that serve a very important function in what we want to discuss today in terms of the natural means by which the airway is cleared. Then the trachea gives rise to the major bronchi, right and left, and then each bronchus continues to bifurcate. And we know that between the trachea and the alveoli, there are 23 generations of bifurcation. Of the first 16, there are no associated alveoli. So they are referred to as the conductive airway because all they do is to conduct the air towards the alveoli. Then by the 17th generation, we begin to have some alveoli associated with the bronchioles. So we talk about the transitional bronchiole. And then it continues until we get to the lump of alveoli that are referred to as the AC9. Now, we now come to the issue of the secretion. So I've already glossed over what these images represent in terms of the airway and their functions. That's the C cartilaginous ring of the trachea and the smooth muscle cell that is able to contract and relax to vary the size of the lumen of the airway. Now, this is showing the epithelial layer along the airway. And here we can see the columnar cells. We can see the cilia. And then above the cilia, we can see the mucous layer. Particles that escape the hair follicles in the nasal cavity also get trapped by the mucus that lines the airway. And so, in order to get rid of such particulate matter that are undesirable within the body, the mucous layer is usually moved, in a direction towards the head to get to the upper respiratory tract, where it can then be expectorated, supported by the cough reflex. Now, along this line, we have, the goblet cells and the, that secrete mucus, and the epithelial cells that also secrete mucin. And this constitutes the secretion along the airway. Now, I've spoken about the bronchial tree and the bifurcation up onto the level of the alveoli. I've spoken about the number of generations that of bifurcation of the airway before we get to the alveoli. And that's what this diagram is illustrating. Now, coming to the secretion that we actually get engaged in wanting to clear. So I've spoken about the goblet cells. I've spoken about the submucosal cells that secrete mucus. And this process of secreting is a continuous thing, such that, just like we continue to secrete saliva in the mouth throughout the day and throughout life. That's exactly how the airway secretion is formed continually. And there is an average quantity in a healthy individual produced per day. So we say that the normal daily production is about, 10 to 100 mils. You can imagine that very wide variation, because there are a number of factors that determine or influence or affect the amount of secretion that is produced. And this basal quantity that is produced is highly essential for the health of the airway. Because without that secretion being there, the airway will be highly susceptible to damage and invasion. Now, talking about the secretion itself now, contains mostly water. Even the human body is composed chiefly of water. Now, it also contains mucin, which is a glycoprotein, and then it contains electrolytes, especially sodium, chloride, and potassium. And the sodium and the chloride ions are very, very important because they play a role in terms of the amount of secretion that will be produced per day. The airway secretion is essentially isotonic with plasma. And sodium, being osmotically active substance, any fluctuation in its quantity or in its location will influence water distribution. So it is not strange that the sodium ions in the airway influence greatly the daily secretion production. Now, because the mucus secretion is isotonic with plasma, if we now have any situation whereby the sodium content rises and sodium gets secreted into the airway, it's going to draw water to itself, and there's going to be a copious production of secretion. Whereas if the sodium ion content falls, the water content will also fall. And in fact, this has also been noted to be a determining factor for the need for airway clearance intervention. Because when the sodium content is lowered, and therefore the water content is low, the secretion that will be produced is going to be highly viscid. It's going to have a high viscosity. You know, it's going to be thicker than normal. And when this secretion is more viscid, then it can overwhelm the natural clearance mechanism, which is the mucociliary escalator system. And so support will then become necessary to move the mucus. So we can see the value of the electrolytes, especially sodium ions, in the airway secretion. Of course, it also contains lipids, and then because it also is a form of innate immunity. When we talk about immune mechanisms, we talk about innate immunity, and that constitutes about 2 levels. The first level of innate immunity are the membranes or barriers, like the skin, that keeps bacteria out of the body. The second line of innate immunity are some of these secretions. Just like we have gastric acid in the stomach, the acidic environment can actually deal with certain things that are ingested and render them harmless to the body. So likewise, in the airway, the mucus secretion contains a number of antimicrobial peptides, as well as some lysozymes that are capable of attacking any foreign thing that finds its way into the body through the airway. And then, of course, we have some cells. Sometimes the neutrophils, and in some instances, the tissue macrophages. Now, I make mention of the fact that the normal airway secretion is, at the basal rate at which it is produced, 10 to 100 mils per day, is very important for the health of the airway because they serve some functions. And so this slide is presenting the functions of the airway secretion. Number one, it is capable of trapping particles and pathogens that are inhaled, those that escape the hair follicles in the nasal cavity. Then it also hydrates and protects the airway epithelium. Then it enables mucociliary clearance because it is by virtue of its presence that the airway can be cleared of particles and debris that has found their way into the place. And then, like I mentioned earlier on, it provides a form of innate immunity or defense function. Now, normally, a healthy individual does not need any airway clearance intervention because there are systems in the body that handle the assignment when the production rate is within the normal range. It is when the rate of production or the ability of the clearance system to clear what has been produced becomes limited, that intervention becomes necessary. So this natural system is referred to as the mucociliary escalator. It's a compound terminology, muco from the mucus, and then ciliary from the cilia. In other words, it is the combined effort of both the secretion, the mucus secretion, as well as the cilia in the airway to move these things and clear the airway. So the escalator system consists of the ciliated epithelial cells as well as the mucus layer. And when we talk about the mucus layer, there are two distinct layers of mucus. In between the cilia as they stand, there are secretions in between them in the interstices or crevices of the cilia up to the height of the cilia. This is referred to as the periciliary mucus. Periciliary mucus. Then, beyond the height of the cilia, there is also a film of the mucus that traps the particles. And the cilia, as they beat and move in their flagella-like motion, they move that airway floor mucus, airway floor mucus towards the throat so that it can be expectorated. And here we have the peak frequency to be between 12 and 15 hertz. This is the frequency at which they beat in order to be able to perform this function. So from this, we can observe that if anything should affect the cilia, either by slowing them down in terms of the frequency of their beat, or outrightly prevent them from the ciliar flagellar-like motion, then airway clearance is going to be compromised. Now, when this function is going on normally, the motion moves the mucus towards the pharynx, and then it is either swallowed by the individual or coughed out or expectorated. Now, I spoke about the fact that the daily production rate varies widely between 10 mil and 100 mil per day. How is the production regulated? How is it controlled? We are familiar with the principle of homeostasis, where the body wants to maintain a kind of constant, relatively constant internal environment. So, in terms of the quantity of the secretion, there's also a homeostatic control. And there are three major controlling factors. You know, I say major because there are some other minor things that could also affect, but they are not necessarily regulatory. Now, the autonomic nervous system, you know, the parasympathetic system is capable of increasing secretion. Those of us that learned pharmacology will remember the Otoliowi experiment. And then the usual illustration of the antagonistic or opposing function of the sympathetic and parasympathetic systems. You will recollect the image of the man that was presented where the parasympathetic system is highly active and another where the sympathetic system is highly active. In the man in whom the sympathetic system is highly active, it is likened to a man that is going through a bush path, and then suddenly he hears the roar of a lion in the bush. Immediately, the fight or flight response will be triggered. And in this instance, the man wants to run for his dear life. So it is the sympathetic system that will be activated. And by virtue of the activity of that system, there's going to be dilatation of the pupils of the eyes so that he can see the road very clearly as he is running, so that he will not stumble and fall, and then the lion will catch him there. So he needs for his eyes to really open wide. Now, the respiratory system and the cardiovascular system will be activated in order to be able to supply more oxygen to the muscles that are engaged in this flight response. And remember, the oxygen is going to be transported to those tissues through blood. So circulation is also going to be stimulated to be able to deliver sufficient amount of oxygen to the contracting muscle cells. Now, the sympathetic, on the other hand, is known to have variable effects, and the effects will differ based on certain other factors that are also involved in the regulation. So there are instances when the secretion production may increase. There are other instances when the secretion production can actually decrease, and it is still the sympathetic system that is working. The second line of regulation are the reflexes. If the cough reflex, for example, is depressed, then the amount of secretion is going to be minimal. But where the cough reflex is stimulated, there will be a lot of, and in order for the airway not to be damaged, the body will respond by producing more to take care of the wastage. Irritants can, of course, also increase secretion production, just like when we talk about this catarrh and things like that, through the mechanism of histamine and allergic reaction, there can be increase in secretion production. Another regulatory line is the environment and some internal stimuli. Talking about environment in the first instance, depending on how pure the ambient air where the patient or the individual lives is very, very important. That's why we have some of the respiratory disorders that are referred to as the pneumoconiosis, because they are caused by particulates that are suspended in air in various work environments. So there are certain workers that are more susceptible to the pneumoconiosis than others. Those who work in dusty environments, either sawmill, quarry, where there's a lot of stone dust in the air, those who work in the asbestos factories, and so on and so forth. So these are the mechanisms that regulate secretion production. This is important because when we now have a case either of excess production or insufficient production, we can then know which among the regulatory systems that we will go to disturb. Now, talking about the range of production, it shows that the secretion actually varies widely. Unlike other parameters like body pH, we know that pH of the body fluid is maintained closely between 7.35 and 7.45. That's a range of only 0.1. But look at the daily secretion of airway secretion. 1, to 10, in terms of 10 and 100. That's ratio 1 to 10. So these are listed items are those that cause such wide variation in this parameter. The first one is the circadian rhythm. Either weather, ambient temperature, humidity, and things like that. Then we have the environmental exposure. There are studies that have compared, even among police personnel, that have compared policemen who control traffic on the highway and other policemen that do office work. So those that control traffic, they have this additional exposure to exhaust gases from the vehicle. And so in such people, you can see them secreting or producing larger quantity of the airway secretion than those who work or stay where the ambient air is cleaner. Then we have hydration status. How well hydrated is the individual. Now, the next one is physical activity. Of course, temperature, body temperature, will influence the secretion production. And physical activity is something that will either directly or indirectly affect body temperature. Now, we want to look at factors that affect the clearance of the secretion. The secretion has been formed and it needs to be cleared. What are the things that can determine whether the fluid will be cleared or it will not be cleared? Topmost is the function of the cilia, because it is the movement of the cilia that produce the escalator function. On its own, mucus cannot move against gravity. And ciliary function, is itself affected by temperature. I've mentioned that when I was talking about physical activity. And of course, humidity, because that will determine how much of water vapor will be present in the air that the individual is breathing in. And then, of course, medications. We are familiar that a lot of us, we take one form of medication or the other. And some of these medications have influence on the airway secretion. Take, for example, somebody who feels that he is prone to developing cold and goes to buy this anti-rhinitis Actifed. Now, that is going to dry up the airway. It's going to drastically reduce the amount of secretion that is formed. Another factor that can affect clearance is the viscosity of the mucus. Like I mentioned, if the mucus is very viscid, because of reduced water content, then it becomes tougher for the cilia to move. The airway anatomy, either in terms of bronchospasm or bronchodilation, but there are also instances whereby the architecture of the airway can vary based on the posture of the head. So all of these things can affect secretion clearance. Of course, positioning and gravity. And then the effectiveness of the second, the effectiveness of the cough reflex. That's why in some instances we talk about ineffective cough. The patient can still make effort to cough, but there is no sufficient power behind that cough to move the secretion and to expectorate. Sorry, I'm coming just a minute. I'm having some heat reaction here. There's no light. So just give me a minute to put on the fan. Yes, thank you. I'm back. Sorry for that interruption. I was beginning to sweat. Yes, so now having seen the issue of the production of the airway secretion and the fact that the rate of production could vary widely, and certain things may actually stimulate the production of larger quantity. And then some of the processes involved in clearing it could also become compromised. For example, when we talk about the effect of anesthetic agents on the cilia in the airway, anesthetic agents depress the function of cilia. And so when the cilia is sedated and cannot move, then there will be accumulation. of the fluid or the secretion within the airway. And in such situations, the natural process will now need a helping hand. And that's what chest physiotherapy is all about. So we say chest physiotherapy is an aspect of bronchial hygiene because there is a process that naturally takes care of it. And this process can become overwhelmed. So chest physiotherapy comes in as that helping hand. And when we talk about chest physiotherapy, it involves quite a number of activities and intervention, including even mere turning the patient from one position to another. And then, apart from turning, because gravity acts on even the human body, there is a way that we can take advantage of that force of gravity to support the clearance of the secretion by positioning the human body such that the throat or head of the patient through which the secretion is supposed to either be audited can, get affected. We position such that gravity will push the secretion down along its own direction and drain into the larger airways where it can easily be expectorated with the cough reflex. And when we take advantage of gravity that way, we talk about a procedure that is described as postural drainage. In other words, we are draining the secretion in the airway, taking advantage of positioning in certain postures, positioning in certain ways. Along the line, when we come to postural drainage proper, I'm going to show us a video that shows the bronchioles and how in postural drainage, it can, depending on the bronchopulmonary segment that we are trying to drain, how that bronchopulmonary segment, the major bronchiole supplying it, can be positioned such that the secretion of fluid in it drains towards the larger airway for eventual expectoration. It also includes some manual techniques performed by the therapist primarily, but with training, which the patient could also learn, to apply on himself or herself. We also have some specialized cough techniques, that are precisely described as directed cough. And sometimes the techniques, any of them could be used in isolation. Any of them could also be used in conjunction with other procedures. So when we want to implement chest physiotherapy, what are the goals that this procedure can be aimed at. The major one is to move the bronchial secretion to the central airways by the aid of the force of gravity to externally manipulate the chest through some manual techniques like percussion, like vibration, like shaking, to eliminate secretions by cough through expectoration, or by elimination of such excess secretion through mechanical process, which is referred to as suctioning. Now, here we have listed various techniques of chest physiotherapy. Techniques that are aimed at clearing the airway clearance techniques. Techniques that facilitate the clearance of the airway. Not that they will by themselves clear the airway, but when they are implemented, they make it easier for the specific processes that are supposed to clear the airway to do it with less stress. And other techniques here include those that can facilitate the ventilation pattern. What is the value of this particular set of techniques? We learned, that ventilation has to do with the movement of air into the lungs and out. Now, for the mucus to be cleared, it is the movement of air over the column of the secretion or the mucus creates a kind of shear force. And when the shear force becomes greater than the surface tension in the mucus, then the mucus will move. So, chest physiotherapy includes some procedures that will manipulate ventilation pattern that will cause the shear force to be increased in order to be able to move the secretion. And of course, we also have mobilization and exercises, because when the patient is mobilized, the cardiovascular system and the respiratory system are excited or stimulated, and they function better. And this increase in performance will also assist in the movement of the secretion. So these are the list of the various mechanisms that constitute chest physiotherapy. And we are going to, in the course of today's workshop, look at the traditional techniques, the traditional methods, and then the more recent methods that have also taken advantage of improved technology. So we talk about instrumented techniques. Now, this is about airway clearance techniques. And when we talk about airway clearance techniques, it is all encompassing. Chest physiotherapy has to do with this extrathoracic manipulation of percussion, vibration, shaking, use of position so that gravity can assist and everything under postural drainage. But we have other techniques that involve manipulating the breathing pattern of the patient. We have other techniques that has to do with the use of certain devices. Some of the devices are active, some of them are passive. What do we mean by active and passive devices? When the patient has to expend energy for that device to work, that's an active device. In other words, a voluntary effort of the patient is required. But where the device is either automated or is being driven by a clinician such that the voluntary effort of the patient is not required, then we talk about passive devices. Now, these techniques use mechanical means to manipulate the flow of air. They use mechanical means to aid the mobilization of the secretion towards the head. They use mechanical means to facilitate evacuation by coughing, by assisting the effort at cough or by even stimulating the cough. Here we have the list of the airway clearance techniques in terms of their categories. We have some that involve breathing maneuvers. They have to do with the way the patient breathes. And so the secretion gets cleared by modifying the way the patient breathes. We have the gravity-assisted drainage, which is the traditional one of postural drainage. Then we have manual techniques, that involves the use of the hand, like the percussion, like the vibration, like the shaking. And then we have mechanical devices, like the insufflator, exsufflator, like the acapella, like the hornet, like the flutter. So these are mechanical devices. We also have the high frequency chest wall oscillator. Now, how do we arrive at what airway clearance technique to use in a particular situation to help a patient? Either they influence the choice of device, or they influence the adherence to prescribed intervention, or they influence the efficacy of the secretion removal strategy. we have about 5 here. The first one is the patient's age. And we know that physiotherapy treats patients across the continuum of life. We manage neonates, we manage infants, we manage children, we manage adolescents, we manage the youth, we manage the middle age, we manage the geriatric. Now, there are some procedures that will be applicable amongst the youth or the older children that will not be appropriate for an infant, not to talk about a neonate, because of the level of cognition. And even in terms of level of cognition, there are some of the things we may do with a youth that we will not do with an elderly person, either because of senility problem or that the person has become weaker and will not be able to generate the magnitude of the effort that is required for that line of intervention, which a youth has found easy. Another factor is the severity of the disease. You know, when the case is mild, there are procedures we can employ that if the condition is severe, they will become inadequate to address the matter. You will have to look for another technique that is able to confront that current patient situation. Another one is about the ease of use. It is one thing for a device to be capable of solving a problem. It is another to be easy to use. When a device is difficult to use, its utility will necessarily drop, because there will be quite a large number of potential clients that will find it difficult to comprehend either the instruction that will make him use the equipment effectively, or it outrightly becomes confusing to him in terms of the procedure to follow. So we want to use a method that the client that is being managed can understand and has the ability or the capacity to use it. And of course, right from our beginning to learn about clinical conditions, we know how important the comfort of our patient is. So the patient's comfort is also a very important factor. And last but not the least, and in particular in an environment like our own, it cannot even be the least. A good number of times, it can even be the most important factor, and that is cost implication. You see, it's not sufficient for us to know that a certain device or a particular technique or method has evidence that it works. What's the cost implication of implementing that care? The patient that we want to see, can he or she afford to pay the cost implication of that procedure? However, all said and done, when managing a patient, the clearance technique that will be considered to be efficient is the technique that will eliminate most of the fluid within the shortest time and will demand for the least of energy. And a good number of times, we also look for procedures or techniques that the patient could be able to carry out on his own or on her own while away from the clinic, at home with himself or herself. The reason here being that the patient is more with himself or herself than he is with us in the clinic. So whatsoever the patient is able to do for himself or herself outside of the clinic will go a long way in complementing whatever we are doing at the clinic. So here we have listed benefits of airway clearance techniques, what the patients have to benefit when we implement the airway clearance techniques. And why it is often preferred over the traditional methods. The traditional methods, you know how cumbersome it can be to begin to arrange the plinth, raise the plinth at, at a certain height, and then position a patient in a particular way. And then the stability of the plinth, you cannot even vouch for it. And then the comfort of the patient is not ideal, and so on and so forth. So by virtue of this, the airway clearance techniques, the more recent ones, are often preferred over the traditional or the conventional method that have been reported to cause a lot of discomfort, that subjects the patient to a possible risk of reflux, that could also be attended by oxygen desaturation. Sometimes dyspnea can even set in, which is shortness of breath. And then a good number of times, there had been cases where patients report headache after the implementation of the traditional procedure. And to the physiotherapist, sometimes in trying to assist the patient or in trying to reach to the patient in terms of the physical procedure, there are lots of ergonomic compromise that end up affecting the health of the physiotherapist. Here we have things that will indicate for airway clearance techniques: cystic fibrosis, especially in children. It causes dehydration. And so often, apart from the fact that there is excess secretion, the secretion is even very viscid and therefore difficult to move. Atelectasis, when the alveoli cannot open up. And when they cannot open up, there's no way you have a large volume of air behind the column of the secretion that will, engage in the shear force to move the column of fluid. Respiratory muscle weakness, because that will compromise the effort in cough. Bronchiectasis, mechanical ventilation, neonatal respiratory distress syndrome. These are some of the issues that may cause chest physiotherapy and airway clearance techniques to be required for the patient. Just like we have things that will indicate the need for airway clearance techniques, there are also things that when they are present, they could cause complications if the procedure is implemented. So we say that they are contraindications. In other words, even though this patient could have benefited from this procedure, but because this procedure is present in the patient and whatever, he cannot be put through that procedure at that auspicious time. So we have them listed, when the intracranial pressure exceeds 20 millimeters of mercury, when the head and neck are involved in injury. This is an additional list. We don't want to belabor that because of our time. The material will be available. Now, apart from contraindications, when we say that it is not advisable to use the clearance techniques, we also have situations where their presence will not necessarily preclude the use of the clearance techniques, but you have to implement it with some extra care by observing certain cautions. And these are the things that are listed in this particular slide. When there is uncontrolled hypertension, when the abdomen is distended, when there is surgery of the esophagus, when there is hemoptysis, and when the risk of airway aspiration is high, then it has to be done with a lot of caution. This is showing us additional list of cautions. Yet another addition. Now, we said as part of our objectives that participants will be able to understand how the various airway clearance techniques work. And when you understand how they work, then you can look at the pathophysiology presenting in a particular patient and know which mechanism will address that pathophysiology, so that airway clearance techniques are not prescribed blindly, but there is strategy in their use. For postural drainage, with the other adjunct procedures in the traditional method, they rely on the force of gravity. So they want to position the patient, they want to make impact so that the secretion can be dislodged from its attachment and things like that. But the modern airway clearance techniques, they rely on ventilation and the flow, the airflow, how it affects the mucus. And so they mostly focus on how to get the airflow behind the mucus. Just like we know that if a vehicle malfunctions and we want to jumpstart that vehicle by pushing it, if people stay by the side of the car to push it, whatever force they will be applying cannot be fully transmitted into moving the car because their force will be directed at an angle. And so the force that will be effective is going to be F cos theta and not absolute F. But imagine, instead of standing by the side, if the people trying to push the car come behind the car from the boot and they all push in that direction, then it is all the force that they have transmitted that will be effective in pushing the car forward. So that's the focus of the modern airway clearance techniques. I made mention of the issue of the shear force. We learned about the shear force in biomechanics. When there's a thick layer of mucus and air is moving over it, there's a shear force it generates that move over the column of the secretion. If the force is strong enough to come behind the mucus to break the surface tension, then the mucus will move. But if the force is less than the surface tension, the air will just go and the mucus will remain. I want us to look at this diagram. Let me pick my annotator. Let me pick a pen. And let me pick a color. Okay, let me pick the weight of this thing. And the first instance. And then the shape is going to be a free drawing. And then the color, let me pick red. So that it will contrast from all that is on the diagram, okay? Okay. Let me pick the annotator. Yes. Okay. Now, are you able to see my pen that I'm moving? Are you able to see my pen moving over this diagram?
Yes.
Yes.
We can see.
Yes, sir. Yes, sir.
Yes, sir.
Okay. Now.
Yes, sir. We're seeing your pen.
Yes. Thank you. Now, when we look at this mass of mucus, there are certain forces that will be present. Now, the force that hold the various particles together is the cohesion between the particles. If you want to break it like it is broken in this place, then you must apply a shear force that is greater than the cohesive force. It is that greater shear force that will cause a cohesive failure. Now, look at this gap that has been created. Look at this gap. Imagine this gap. It is now possible for air to enter into this place and push this column of mucus in the direction of the force. But if the shear force had not been sufficient to create this cohesive failure here, air will just move and flow over the surface and continue going. So part of the focus of the modern airway clearance technique is to produce flow of air at a force that will be greater than the cohesive force, and therefore cause cohesive failure in the column of mucus, so that it will become easy to move the mucus. Now, you can see by virtue of that cohesive failure now, look at how it is possible for this mucus to be moved, and then it is now going in that direction. Then, coming to the right hand side here, we have the mucus. We have the lining of the airway. The force that holds the mucus onto the lining of the airway is the adhesive force. Just like when we talk about the adhesive tape, like your cello tape, like your paper tape, and you have gum on one side, and then you paste the plaster or sellotape or paper tape on top of the surface of this table. That plaster will hold onto the wooden table, and there is a force of adhesion because of that gum. But if you want to remove the plaster, you must raise it at the end and then lift it with a force that is beyond the adhesive force before it can be stripped off the surface of the table. So likewise, when you look here, the strategy of the modern airway clearance technique is to cause the air to come underneath the mucus and tear the mucus off the lining of the airway by causing adhesive failure. And then it becomes easy for this column of mucus to be moved. And that's what you see here. Can you see this part? Look at how the mucus is adhered to the surface of the airway. It will be almost impossible for you to move this. But if the air has been directed to, first of all, cause this adhesive failure, look at how the mucus have been stripped off the surface of the lining here. It's no longer attached to the lining. It then becomes easy for air to come underneath here and push this column of mucus ahead, just like it is already happening at this end. It's already moving because of this adhesive failure. This is also already moving because of this cohesive failure. So that's the strategy with which the modern day airway clearance techniques work. Let me clean off my pen. So let me pick the eraser. Okay. Now, based on the strategy employed by the techniques, they have been categorized. And this slide is showing us the broad categories of the techniques. We have those that fall under breathing techniques. In other words, what we do is to modify the breathing pattern of the patient to achieve what we want. So those are breathing techniques. And the most popular one that people talk about today is the active cycle of breathing technique. Active cycle of breathing technique, ACBT. Now, we also have those that fall under the mechanism by which the therapist uses his hand to achieve certain things. And in some instances, the patient will also be taught to carry it out. And the implementation of the techniques involve some form of hands-on. Those ones come under the umbrella of manual techniques. And then we have some that fall under the category that there are certain mechanical devices that have to be used. Either the flutter or the acapella or the hornet. Those are, techniques that fall under mechanical devices. And those that come under breathing techniques, we have the active cycle of breathing technique, we have the autogenic drainage. Those that come under the manual techniques, postural drainage, clapping, percussion, vibration, shaking, and so on and so forth. And those that come under mechanical devices, we have the PEP devices. We have the oscillatory PEP devices. We have the high frequency chest wall compression system. Then we have the intrapulmonary percussive ventilation. And then we have mechanical cough assist. Another method of classification categorizes the clearance techniques into 4, unlike the previous classification method that puts them under 3: breathing, manual, device. Under this alternative classification method, we have 4 categories. They are based on, are you applying whatever you are doing within the patient's body or applying it outside? So we have extrathoracic manipulation because it is from the surface. Something like clapping, shaking, vibration will fall under that one. But when you talk about intrapulmonary percussive ventilation, that is taking place through a device inside the mouth. That is intrathoracic or oral manipulation. Then you also have whatever device or technique that you are using. Does it require voluntary effort from the patient or not? Those that require voluntary effort from the patient, those are active devices or active techniques. But those interventions that do not require active participation of the patient, no need for voluntary effort being put in, those are passive devices forming the 4 categories under this second classification method. And by the special grace of God, in today's workshop, we are going to look at examples from each of these categories. So, based on this new classification now, we have a list of those that fall under the 4 classes. Under extrathoracic manipulation, we have postural drainage, chest percussion, vibration and shaking, high-frequency chest wall oscillator. Under intrathoracic manipulation, we have bagging or manual hyperinflation, we have intrapercussive ventilation, and then we have cough assist device. And under active devices or active techniques, we have the PEP therapy devices like the acapella, the flutter, the easy pap, the cornet, and the quake device. And under active devices or techniques, we have active cycle of breathing technique, autogenic drainage, and forced expiratory technique. Passive devices, the easy pap, the inspiratory muscle trainer, the threshold trainer, the resistive trainer, and then the isocapnic hypapnea trainer. These are passive devices where the patient does not make any voluntary effort. So that brings us to the end of the first presentation. Can we take any few questions before we move on to session 2? Any question? Okay.
Well done, sir.
Yes, ma'am.
Thanks for your presentation, sir. It's really quite interesting.
Thank you very much.
Honestly, my question is, okay, some of this modern airway clearance.
Yes.
I was hoping to see some of them that you mentioned, and then the utility in the ICU.
Yes, we are coming to them. We are going to pick them one by one.
Okay, sir.
This first lecture is just to create a kind of foundation for us to know that these procedures, they vary and they have principles that guide them. And therefore, when we have a patient, I've observed something a good number of times. Immediately they come across a patient, somebody will just say incentive spirometry. And you look at the pathophysiology, you cannot see what indicates for incentive spirometry. But because people have just recently heard of it and whatever, it's like, oh, that's what is in vogue to treat patients that have respiratory issues. And so it's almost every cardiorespiratory patient they want to use incentive spirometry for. So that we want to highlight it, that there are principles that guide your choice of intervention. That's the basis of this first presentation. We will now begin to look at them category by category, bring out example, talk about the mechanism by which it works, and therefore, in what situation will its use be relevant in the clinic. And by the time we will have covered all of them, like I said about session 6, which is case-based discussion. We are going to see that we have created 3 case scenarios. One has to do with a patient that is postoperative. One has to do with a patient that is COPD. That is not a surgical case. And one has to do with an infant, a child. To see that, you know, our line of thinking, our clinical reasoning has to be tailored. You know, it has to be patient-centered. This is an infant, this is a child. And therefore, what are the problems that we will come across in this patient who is just a child? What are the things we need to consider before we decide on which device or which technique to use for him based on his age? Then the other case is like, okay, this is a post-operative case. There's going to be some pain, some tenderness, some this, some that, and whatever. So that even though this is the problem he's having, D, A, B, and C will have been able to solve that problem. But because this is a post-surgical case and there's pain, then A will not be appropriate. Okay, because there is also this comorbidity that has been mentioned in the description of his case. C will not be appropriate. Then it means we will only be able to use B. You know, that's what we will be seeing when we are discussing those cases. So this first session is just foundational. Any other question?
Good afternoon, sir.
Good afternoon. You're welcome.
Thank you. So I wanted to ask how you talked about the factors affecting secretion clearance, and then
Yes.
you mentioned airway anatomy. I'd like
Yes.
to understand how airway anatomy affects clearance, because I did not really get it.
Yes. Now, take for example, when the person stands erect, there's a shape that the trachea has, and there's a diameter that it has, and therefore flow through it will be influenced by certain, if we are to do a kind of mathematical modeling, there's a way things will flow in it by virtue of that shape and that diameter. Now, when you do a head forward posture, the trachea becomes straight. And so in that situation, let's imagine a drainage system on a street, this gutter, and it is raining, and flood water is flowing through it. When the gutter or drainage path is straight, there's a way things will flow in a laminar fashion inside it. When that gutter or drainage path is bent or twisted, there's a way it limits the speed at which the flood water will flow through it. Then, when there is this chin up posture of the head, there is also a kind of collapse of the airway at certain points where the diameter of the airway will become narrower than the natural diameter. And where it becomes narrower, resistance is going to increase. You know, there's going to be just like when you are talking about flow of blood. When there's room, in a path, there's going to be greater peripheral than when there is vasodilatation. Flow is going to be greater. So the same thing happens in the airway in terms of factors that will affect flow in them. And remember, we said that the various airway clearance techniques that are modern, the strategy is to bring the air behind the mass of mucus and cause the flow to be forceful enough to push the mucus ahead. So if you now have anything in terms of the shape of the airway that will slow down the velocity of the air flowing through it, you have already weakened the effectiveness of that method to clear the airway. Let me use another illustration that we may probably be familiar with. Now, a good number of times in our various compounds, we have this small gutter, especially maybe from behind the kitchen. The kitchen drain enters into that gutter. And then sometimes some dust, sand, and whatever, and some debris will remain inside that gutter. You can have a tap that is open and is running smoothly, and the water will just be flowing on top of that debris inside that gutter without moving it. But if you take your bucket, you take it to the tap, you fetch one bucket of water, you now bring it to that point where you have that debris, and you forcefully splash that bucket of water against that point where you have that debris. You see that water push the debris and it creates a flow. I don't know how many of us you are familiar with what I've just tried to describe. Hello?
Hello, sir.
Yes. Am I clear?
Yes, sir, you are.
Thank you very much. Yes. Any other question before we now move on to session 2? Okay. Okay, sorry, there's a message on the chat. Let me see whether somebody is dropping a question. Okay, I can't see. Okay. So we are welcome to the second presentation. And we are looking at traditional manual techniques. Traditional manual techniques. Now, in going through this particular session, it is hoped that by the end of this second session, participants will be able to identify and describe manual techniques used in traditional chest physiotherapy. They will be able to demonstrate correct technique for percussion, for vibration, and postural drainage. They'll be able to apply clinical reasoning to select appropriate manual technique for different patient conditions. So that when we are managing a patient, we don't think that it is one size fits all. No two patients are the same. And whatever line of management, we must endeavor at all times to make it to be patient-centered. Now, as an overview of the traditional chest physiotherapy techniques, we said the manual techniques, they aid the clearance of the secretion by using external mechanical forces. External mechanical forces. Mechanical forces that are not from the patient, that are not within the patient, that has to be applied onto the patient. And these techniques include postural drainage, percussion, vibration and shaking, directed coughing, and huffing. So looking at postural drainage, we said it is the gravitational clearance of secretions from specific bronchial segments by using certain different positions, depending on which bronchopulmonary segment we want to drain. We position the patient such that that bronchopulmonary segment will be topmost, such that whatever secretion is there can drain down along gravity. So gravity helps to move that secretion to the trachea so that it can be coughed up. So when we are talking about postural drainage, the main goal is to drain mucus from the affected segment or lobe to the larger airway so that it can be coughed up. That's the goal. And it's not every patient that is going to require postural drainage for all the lung segments. Therefore, at any particular point in time, there must be patient selection. Which patient needs this procedure? And this patient that needs postural drainage, what position must he be put? There are some postural drainage positions that you need the plinth or the bed to position the patient. There are some postural drainage positions that the patient can sit on the chair without necessarily going on the couch. Therefore, whatever procedure we are following must be based on our clinical findings. Part of how we arrive at the clinical finding in this case of postural drainage may be in terms of X-ray that shows congestion in a particular location. Now, when we look at the lungs, the segments that are above, somehow, especially once they are above the two major bronchi, right and left, they already are aligned with gravity. And so they are not often affected by accumulation of secretion like the lower and dependent parts of the lungs. So the upper lobes and segments rarely need postural drainage. For example, if you now come across any accumulation in this portion of the lungs, you can almost be sure that it is not postural drainage that is going to solve the problem. Because already in their erect posture, they have already made that fluid or secretion available for gravity to push down. And if gravity has not naturally done it, it is not the process or the procedure of postural drainage that will now move it. Something else will be needed to handle it, not gravity again. So the lower lobes, they require drainage more frequently. And a good number of times, we have said there are some factors that affect clearance. One of it is hydration, how hydrated the person is. So that if a patient is dehydrated, the secretion is going to be viscid and the adhesive force is going to be very high. The cohesive force is going to be very high. So for you to move it and, clear it will require a lot of effort. Unlike if the patient is well hydrated and therefore the secretion is not viscid, it's tenacious, and it's able to flow freely. Just like, let's look at groundnut oil and palm oil. palm oil is more viscid than groundnut oil. Therefore, if you pick a flat sheet and you slant it a little bit, and you pour palm oil on one side and pour groundnut oil on one side, the groundnut oil is going to run faster down that surface than the palm oil because of the greater cohesive force and adhesive force of the palm oil compared to that of the groundnut oil. Therefore, sometimes before postural drainage is implemented, there may be the need to administer a means by which the secretion can be broken down. Administering a bronchodilator will dilate the chamber and probably shake loose from some of the secretion that is glued to the surface. Even water could be given so that the person becomes better hydrated. Then we also have what we call the mucolytics. Mucolytics. So these are some of the things that could serve as adjunct to the postural drainage implementation. Or there could even be nebulization with water vapor, which will dissolve the mucus and make it freer to move. There is an ideal frequency by which it should be administered. I don't want to belabor that because we want to deal more with the procedure rather than the prescription. The prescription can always be seen later. Now, the best times for postural drainage are listed here, but the important thing to note is that it is not advisable so close to a meal because it can induce vomiting. And we are all familiar with the fact that when you have just eaten, there's this tendency to feel lazy and tired. So if it is close to a meal, apart from the risk or the chances of a vomit, fatigue could easily set in, and the patient may not be able to cope with the stress that the procedure requires. This is just a diagram showing us the various lobes and the bronchopulmonary segments in the lungs. And the procedure to follow. Usually, the patient will be put in an appropriate position that is aimed at draining the particular bronchopulmonary segment that is affected. And there is a minimum duration that is required for this procedure to be effective. If the period utilized is less than that minimum, it will amount to a waste of effort and time. It's just like let me give an example. If you need 10 minutes to boil an egg for it to cook and become edible, and now you boil the egg for only 4 minutes, and you decide to break the egg to eat, the egg will not be properly cooked and it won't be edible. So whatever you have put into boiling it, in terms of your gas, in terms of your time, if you have used the electric kettle, the NEPA bill that you have to pay and everything, will then have amounted to a waste because you have not boiled the egg for the minimum duration that is required for the egg to be done. So the same thing about postural drainage. There is a minimum duration that a particular position must be sustained for the effect of gravity to manifest. Now, in that position, you can now apply the adjunct in terms of the manual technique, percussion, vibration, shaking. Those procedures are to aid the effect of gravity. They do not replace the function of gravity. And so the sequence in this procedure is positioning the patient, the manual technique, either percussion or vibration, and then the removal of the secretion through cough. You know, as the mucus comes near the throat, you instruct the patient in definite terms to cough out. Now, we spoke about the issue of documentation. After the procedure had been carried out, there should be a review, especially of the auscultation. Part of what made you to decide or arrive at the fact that the patient needs this procedure is the presence of secretion in certain parts of the lungs that need to be drained. Part of what gave you that information is your auscultation finding in terms of the breath sound that you had over that segment of the lung. Now, having taken the patient through this procedure, you should auscultate again and compare the auscultation finding before and after the procedure. And the outcome of that comparison should be documented to say that auscultation before the postural drainage was this. After the postural drainage implementation, auscultation was repeated. This is the finding. Now, you may want to say that from the sound heard, it is suggestive that there is some degree of resolution in the accumulated fluid. Likewise, also, you need to document the amount of secretion that is expectorated. Therefore, it is not proper for a physiotherapist to take a patient through postural drainage, and when the patient is coughing and expectorating, you ask him to put it inside tissue paper and wrap. Some people do that. They ask the patient to bring out tissue paper, and whatever is bringing out is being, spat into the tissue paper. Now, how do you assess the impact of your intervention? And when that is done, eventually such a therapist will end up putting in the case note, patient's sin, treated as usual. That has not given us sufficient information that will allow for comparison and will allow us to say this is the outcome of your intervention and this is how effective the choice of procedure has been. So we will not be able to build up evidence in our practice here. And sometimes we will then have to begin to depend on the outcome in other parts of the world. And often at times, there are cultural differences. Now, there must also be a record of the color of the secretion. Take, for example, a patient was coughing and the expectorated secretion was greenish yellow before. And later, it is now becoming mucoid and whitish. Without saying more than that, that information already suggests that some things are changing in the patient. One of such is that there is some degree of resolution of the infection, even though that's not written. And that's talking about the power of our documentation. And then, of course, the character of the secretion. Is it tenacious? Is it viscid? What about the smell? What about the taste? And there's usually, especially when we are teaching undergraduates, and immediately you talk about the taste of the sputum, some of them will ask that funny question. I say, how are you going to say this is the taste of somebody's sputum? Are you going to, no? That's going to be a self-reported outcome. Just like when you give somebody a questionnaire and you ask him, what's your age? You can't measure age with your ruler. And you can't measure age with your bathroom weighing scale. And yet, you collect data about patient's age. And how you collect that is by asking the patient. So likewise, in this instance, it's a self-reported matter. So these are the important things to document that will allow for follow-up, comparison, and evidence development. Now, we made mention of the fact that there are different positions to drain different aspects of the lung. And we are going to quickly look at this video. So we can see how that bronchus, by virtue of the way the patient had been positioned, that bronchus had become vertical, such that the secretion there can drain into the larger airway, into the trachea, and then it can be expectorated with the cough. Now, we have some specified positions for different lobes and different segments. But there is something we must bear in mind. If the patient we are managing has had a surgical procedure before, and the surgical procedure is around the thoracic cage, and it has likely modified or changed the exact location of a particular bronchopulmonary segment. When we are positioning for postural drainage, we cannot go and use the picture or the diagram that has been shown us on a chart. There might be the need to make a little adjustment based on maybe the X-ray, the CT scan, or the MRI that is now showing the orientation of the bronchus that serves that particular segment. Because using the chart may not necessarily, again, because of the modification due to surgical procedure, make it to be vertical. And if it is not vertical, then the assistance or support of gravity, that is the motivation for the intervention, cannot be secured. So, again, I want us to look at this. Okay, so we move on. So that's one of the, sorry, I'm trying to move. So that's one of the adjuncts to postural drainage, the chest percussion. And we have the issue of frequency as well as duration. frequency is such that it is to be performed several times a day. And each area, each time should be percussed for between 30 to 60 seconds. And if the secretion is tenacious, then the duration should be longer in order to actually succeed in dislodging the mucus from where it is attached or glued to. And like I said during the first session presentation, some of these procedures the patient can learn or the relative can be taught in order to follow up and to continue even at home to augment what is being done at the clinic. There are areas where chest percussion are not permitted. This slide shows them, and it is because certain tissues or structures may be damaged if percussion is done over them. Now, we want to see the full procedure of this adjunct.
So there's no volume. So please, we're not hearing her. So please, the volume, the video, there's no volume.
Okay, the volume.
Yes, sir.
Okay, let me stop it and then adjust the volume. Is it better now?
Still the same, sir.
It's still the same, no volume.
That's strange because I'm getting the volume here. Okay, I'm coming. But the previous ones, were you able to get the sound then? Did you get the sound of the previous videos?
Some of them, the sound, we hear the sound.
So what could be wrong with this one? Okay. What's but is the
There are some songs. Okay. So how you sing, we sing.
Take the folded towel. My patient is currently inside lying.
what about now?
Bottom of the lung. From here.
Yes, it's working now. We can hear it.
Okay,
Yes,
it's
sir.
better
Yes,
now.
sir. Yes,
Okay.
sir. Thank you, sir.
With a cupped hand and soft wrist, you can start your percussion, either on the side or the back. While you're doing this, you need to ensure that your patient is comfortable throughout and they're not breathless. Percussion should be done between 150 to 200 claps per minute. That's roughly 2 to 3 per second. Once you feel you've done enough at the bottom of the lung, you can then move to the middle of the lung. Move your towel accordingly. At this point, your patient may feel the need to cough and clear, in which case sit them up and allow them to do this. Move on to the middle of the lung, again, either on the side or the back, ensuring the patient is still comfortable throughout. If the patient again feels they need to clear, allow them to clear. Otherwise, feel you've done enough in this area, then move to the top of the lung. If at any point during this the patient feels uncomfortable, please ensure that you move away from this area. Once you've completed one side and the patient has managed to cough and clear, turn the patient, make sure you do the other side as well. Not only can you do it inside lying, you can do it sitting. Place the towel across the patient, continue your profession. You can either do it behind, working from the base up, or you can do it across the front of the chest.
Now, that's about percussion. Now, another adjunct to the postural drainage in terms of the manual technique is vibration and shaking. And this consists of, a compression of the chest wall with the hand and then a vibratory move using the arms to create a vibration. The vibration is a milder form of vibration than shaking. In other words, when we talk about shaking, it's also a form of vibration, but it's more rigorous than vibration. So we say vibration is a less intense form of chest shaking. And vibrations are performed using the therapist's hands and arms to create oscillation of small amplitude and high frequency. But when it comes to shaking, it is the therapist's arms and body that are used. In one, it is the hand and the arms. In shaking, it is the arms and the body. In other words, you use the whole thrust of your body to create a more vigorous shaking. That's talking about the rate at which it is to be done. And then again, the parts of the body to avoid in shaking and vibration, they are also highlighted. And this is talking about the procedure to follow. The instruction to the patient in terms of diaphragmatic breathing, because your shaking and the vibration must be done during the expiratory phase of the patient's breathing. In other words, you ask the patient to breathe in using the diaphragm, and when it is diaphragmatic breathing, it is going to show as the dome of the diaphragm descends and pushes the abdominal content upward. You are going to see the waist, expand out. And then when the inspiration is completed and expiration is taking place, that's when you shake or you vibrate, depending on which one you are carrying out, whether it is vibration or shaking. So
you may put a layer of towel over the chest wall area for comfort. Technique 1. With one hand over the other, place hands firmly on the chest wall over the part of the lung that needs to be drained. Press the top and bottom hands into each other. Instruct the patient to breathe in and breathe out. As patient breathes out, tense the muscles of your arms and shoulders and apply a light vibrating pressure in an inward and downward direction. Instruct patient to cough or half forcefully if the patient feels that secretions are in his lungs. Technique 2. Place your hands side by side, firmly on the chest wall over the part of the lung that needs to be drained. You may put a layer of towel over the chest wall area for comfort. Technique 1. With one hand over the other, place hands firmly on the chest wall over the part of the lung that needs to be drained. Press the top and bottom hands into each other. Instruct the patient to breathe in and breathe out. As patient breathes out, tense the muscles of your arms and shoulders and apply a light vibrating pressure in an inward and downward direction. Instruct patient to cough or half forcefully if the patient feels that secretions are in his throat. End quote. Technique 2. Place your hands side by side, firmly on the chest wall, over the part of the lung that needs to be drained.
Okay. Sorry.
You may put
On to move on. Okay. So now, this is the sequence to follow, and the need to allow the patient to cough after some set of vibration or some set of shaking or some set of percussion. And remember, when we are talking about documentation, we spoke about the quantity of the secretion that is expectorated. So in this procedure, whether postural drainage, the the phlegm or the secretion should be collected in a mug, sputum mug. And usually it is from that mug that it is now transferred into a measuring cylinder in order to get the actual volume or quantity of the secretion. Now, let me say a little bit here, because when it comes to measurement, precision is very, very important. And there are some ways that some error can be introduced even in the figures that we record. If the sputum is viscid, in other words, is thick, when you want to decant it from the sputum mug into the measuring cylinder, some of it can stick to the inside of the mug. And you know, that will be whatever you now measure with this measuring cylinder will be less that quantity that remains stuck with the sputum mug. Now, let me show us the way to go about this. When you now have such a viscid sputum or secretion in the mug, in order to get the accurate quantity, you need some water. You will now take a known volume of water. Let's say you now collect, you take 500 mils of water. You use it, two procedures. You can either add the water to the secretion inside the sputum mug so that it is diluted before you now pour it into the measuring cylinder. So that will have diluted it and it will pour out of the mug directly without any part sticking to the mug. Or you pour it from the mug into the measuring cylinder, then the one that is stuck, you add water and shake it and then decant it also. You now take the measurement. Imagine if you now measure and it is 750 mils. Since you know the volume of water that you added to be 500 mils, the volume of the secretion will be 750 minus 500. So you know that the actual quantity of the secretion that the patient expectorated is 250 mils. Or you have used 200 mils of water. And when you measured 235 mils. It means that the patient's secretion is actually 235 minus 200, which is 35 mils. So that's how you can arrive at a precise and accurate figure when we are talking about these measurements. Am I clear?
Yes, sir.
Okay, thank you. Now, again, in terms of re-evaluation, your auscultation is important so that you can compare your auscultation finding after the procedure with the pre-procedure auscultation finding. So that brings us to the end of the first part of the traditional chest physiotherapy technique. We are going to have a short break according to our program. And I think 10 minutes should be sufficient for that. Dr. Jibrin?
Yes, sir.
Okay, so we have 10 minutes of short break. And then,
okay, sir.
Okay. Yes, sir. Okay.
Okay, sir.
So that people who want to visit the gens, want to stretch their leg, want to straighten their back, can just do that within the 10 minutes. And then
all right, sir. Thank you, sir.
Okay. Ah, 112. Hey. I think it is time I think it is time.
Yes, it's time, sir.
Okay. Because we have a lot to cover. So I want to welcome us back. And we are going straight away to the third presentation. And the third presentation is a continuation of the traditional chest physiotherapy techniques. But I'm going to crave our indulgence to be snappy with this, because we have quite a lot under the new and the modern techniques that we shouldn't waste so much time on the old ones, so that we can cover more ground. So, continuation of the traditional manual techniques. And the objectives remain the same, just that here we are now looking at two techniques that we didn't look at in this second presentation, and that's active cycle of breathing technique and autogenic drainage. I'm going to apologize ahead of time. I thought I had the video on autogenic drainage on my system, but when I was trying to embed it, I couldn't locate it immediately. So if I'm able to locate it and embed it before I forward the something, so good. But the video of active cycle of breathing technique is embedded already. So again, the overview and the directed cough, which is also known as assisted coughing. And when we talk about this assisted coughing, it consists of huff coughing and manual assisted cough. So we are going to look at these procedures one after the other. Huffing, as we are familiar, is forced expiration, but with open glottis. Unlike when we talk about the Valsalva maneuver, which is against closed glottis. So this is against open glottis. And directed cough is a form of forced expiratory technique. This is giving us the historical background and the components of the forced expiratory technique. And how it is carried out. A normal breath is inhaled, and depending on the school of thought, a school of thought says you hold the breath for a brief period. And then you now rapidly squeeze out the air by contracting the chest wall and the abdominal muscle. You know, another school of thought says you may not necessarily hold the breath, that once you have inhaled the breath, you follow it up with the rapid squeezing out of the air. And that the huff should not be violent. And this can be repeated a number of times. And each repetition can utilize a larger volume of inhaled air. In other words, if you start with tidal volume in terms of the breath you take in, you can move on to something like 1.2 of the tidal volume, then move on to 1.4 of tidal volume, 1.5 of tidal volume, and repeat the procedure. So we want to see it demonstrated.
Forced expiratory techniques. Huffing involves taking a breath in and actively exhaling with your mouth and throat opened. It is as if you are misting up a mirror. Perform it 2 or 3 times before coughing. Coughing is key in clearing secretions in airways. It involves taking a breath in and forcefully exhaling with your mouth and throat open.
So we can see the difference between huffing and coughing.
Expiratory.
Then the manual assisted cough.
Manual assisted cough is a technique used to enhance cough strength. It can be carried out in a sitting or lying position. The pressure is applied on the abdomen. For safety, ensure that the patient is well supported. If the patient is sitting in a wheelchair, ensure that the wheels are locked. There are 2 techniques for self-manual assisted cough. Technique 1. Sit up in the chair. Place both hands on your abdomen, between the belly button and the lower tip of your breastbone. Take in a deep breath. Apply pressure in an inwards and upwards movement as you cough. Technique 2. Sit up in the chair. Hold around your knees or thighs. Take in a deep breath. Pull your knees up towards your chest and lean forward as you cough. An assistant is needed if the patient is unable to do manual assisted cough independently. The patient and assistant will need to coordinate with one another for effective assisted cough. This can be done in a sitting or lying position. Assisted cough in sitting position. Sit the patient in a chair with head and body well supported, preferably against the wall. If the patient is sitting in a wheelchair, ensure that the wheelchair is locked. Facing the patient, lower yourself such that your arms are in front of patient's abdomen. You can either bend your knees slightly as though you're in a semi-squat position or kneel on one knee. Place both your thumbs together and spread your fingers wide apart, forming what looks like a butterfly. Put the heel of your hands midway between the belly button and the lower tip of the breastbone. Instruct the patient to take in a deep breath and cough. Apply pressure in an inwards and upwards movement as the patient coughs. Repeat the process until secretions are cleared. If required, you can perform suctioning to remove the secretions. Assisted cough in lying position. Ensure that the patient is lying on a flat surface. Technique 1. Place your hands in the same butterfly position used in assisted cough in sitting position. Apply pressure in an inwards and upwards movement as the patient coughs. And cough. Technique 2. With your arms forward and elbows slightly flexed, place one hand on top of the other on the patient's abdomen between the belly button and the lower tip of the breastbone. Apply pressure in an inwards and upwards movement as the patient coughs. Deep breath. And cough. Technique 3. Place both forearms firmly across the patient's abdomen, horizontally below the ribcage and above the belly button. Apply pressure in a downward direction as the patient coughs. Deep breath. And cough. Breath stacking is a technique used to improve peak cough flow by inflating the lungs with as much air as physically possible. It is also called lung volume recruitment. Breath stacking can be done to expand the lung, improve cough effectiveness and secretion clearance, increase speech volume. For safety, ensure that the patient is well supported. If the patient is sitting in a wheelchair, ensure that the wheels are locked. To perform breath stacking on your own, connect the ambu bag to the one-way valve with the arrow facing you. The one-way valve should only be used during breath stacking. Do not use it during rescue breathing. Connect the mouthpiece after the one-way valve. Use a face mask if it is difficult to seal your lips. Seal your lips tightly around the mouthpiece. You can use nose clip to prevent air leakage from your nose. Take in a deep breath as you gently squeeze the ambu bag. Hold your breath and stack another breath in. Stack 3 to 5 breaths until your lungs are full. You may feel a gentle stretch in the chest. Take the mouthpiece out and cough. If it is difficult to squeeze the ambu bag, you may put the ambu bag under your armpit, in between your legs, or even under your feet. An assistant is needed if the patient is unable to do breath stacking independently. The patient and assistant will need to coordinate with one another for effective breath stacking. This video will demonstrate breath stacking using a face mask. Ensure that the patient is sitting on a chair with head and body well supported. If the patient is sitting in a wheelchair, ensure that the wheelchair is locked. Apply face mask firmly, covering nose and mouth. Support the back of patient's head if needed. Ask the patient to take in a deep breath as the assistant gently squeezes the ambu bag when the patient breathes. Ask the patient to hold the breath and stack another breath. Stack 3 to 5 breaths until the patient's lungs are full. Wash mask and mouthpiece with mild detergent and air dry before keeping.
Now, so we have seen the assisted cough and the breath stacking. And you see that the important thing is to have sufficient volume of air that can be exhaled to push the secretion towards the throat and then subsequent expectoration. Now we want to look at the active cycle of breathing technique, which actually consists of 3 procedures, but is carried out as 4. The 3 procedures if we label them A, B, and C. In the performance, the sequence is A, B, A, C. Even though there are three descriptions, A, B, and C, in the actual performance, they are carried out like 4 stages because A is repeated. A is done before B. It is also done before C. And you will appreciate that principle when we remember the kind of instruction we had when we were learning massage. That whatever massage manipulation you want to administer to your patient, you start with soothing stroking, which will accustom the patient to your touch. You start with soothing stroking, then you now administer the real massage manipulation that will produce the result you want. And if your treatment actually involves 2 or 3 different massage manipulations, you start with soothing stroking, you use the first massage manipulation procedure, and then you go into soothing stroking again before bringing in the second massage manipulation. And then you do soothing stroking again before you bring the third massage manipulation. So you see that the soothing stroking is used like a kind of crossover from one thing to another. So the same way in active cycle of breathing technique, we have A as breathing control, we have B as thoracic expansion exercise, and then we have C as forced expiratory technique. So, but in carrying it out, we do breathing control, thoracic expansion, breathing control, and then forced expiratory technique. And that's when we have had one cycle. And the cycle can be repeated 4 to 5 times. And the essence is to get sufficient air behind the secretion to propel it. So we have the description of the breathing control, which is simply the normal silent diaphragmatic breathing. Then the thoracic expansion, which is like, segmental expansion. But in this instance, it is the entire lungs that we are actually making efforts to get properly expanded. And then the forced expiratory technique, which actually consists of the huffing, 1 to 2 forced expirations or huffs. So let's now see the cycle. You can see in the diagram, can you see my mouse?
Yes, sir.
Yes. So starting from this, you can see even though the image is inverted, it's like you are looking at it from the back. So it starts with a breathing control, which is A. It now goes to B, which is deep breath. Deep breath, which is a thoracic expansion. And then it is followed by breath control, which is A again. And then before you go to, deep breath, and then breathing control, and then forced expiratory technique. Now, so let's watch it carried out.
Active cycle of breathing technique. It is a 3-phase cycle. The first phase is breathing control. Place your hand on your stomach, take a relaxed breath in through your nose and a relaxed, gentle breath out through your mouth. You want to be looking not to expand into the chest, but to expand into the stomach on the breath in. If you find on the breath out it is difficult with an open mouth, you may prefer a pursed lip breath. Repeat this 5 times. After the 5th, move on to phase 2, thoracic expansion exercise. Here, place your hands onto your rib cage. Take a longer, deeper breath in through the nose, and then open the mouth and take a gentle, long breath out through the mouth. During this phase, you're looking to get the movement of the ribs out, like so, and then come back in again on the breath out. Again, on the breath out, if you find it difficult with an open mouth, purse your lips together, and this will make it easier. After the 5th, you can either go back to phase 1, the breathing control, or move on to phase 3, the forced expiratory technique. Here, you can mimic steaming up a window or mirror by using your hand. Take a long breath in through the nose, and then open the mouth to huff out. Again, if you feel you can do it without using the visual aid of your hand, you can continue the practice. You can do it by taking a smaller breath in through the nose and a longer huff out through the mouth, or a longer breath in through the nose and a short, quick huff out through the mouth. At this point, you may feel the need to cough and clear. Active cycle.
Now, the next one is autogenic drainage. And here, it is the normal tidal breathing that is used to mobilize the secretion. You take a deep, normal breath. In other words, you breathe normally, but you allow the breath to be deep, such that every aspect of the lungs is expanded. And then you exhale it in a gentle way. But the difference here is that normal exhalation is passive, in that it is a process that happens as a form of elastic recoil of the structures that were stretched during inspiration. In other words, it's like when you have blown air into the balloon and the balloon is expanded, and you simply stop blowing air into the balloon. you will see the wall of the balloon that had hitherto been stretched recoil and squeeze air out of the balloon. So that's a passive recoil of the stretched structures. But in autogenic drainage, you do not allow the exhalation to be a passive thing. You deliberately use the muscles of expiration. Remember, when we are talking about the major muscle of inspiration, it is the diaphragm. But you have other muscles of inspiration, which is external intercostal. The external intercostal muscle is a muscle of inspiration. But the internal intercostal muscle is a muscle of expiration. So in autogenic drainage, rather than just allow the thoracic cage to recoil, you deliberately use the internal intercostal to squeeze, to actively squeeze the chest back. And that can be likened to a situation where you blow air into a balloon, and after you finish blowing air into the balloon, instead of allowing the balloon to recoil and push out the air, you actually bring your hand and you squeeze the balloon. So the movement of air out of the balloon is a product, or the joint effect of the recoil as well as the squeezing with your hand. So you discover that the air will come out of the balloon with a greater force than it will have come out if you just allow the balloon to recoil by itself without squeezing. The essence of this in autogenic drainage is that this active exhalation adds to the push that will propel the mucus to cause the secretion to be drained. And it is also a procedure that has 3 phases. The first phase is carried out in a way that it will unstick the mucus. Remember, I spoke about the adhesive failure in terms of the mucus being torn off the lining. That's the unsticking. Or when you paste a plaster over the table and you pull it up to unstick it from the table. So the procedure in the first phase of autogenic drainage is aimed at achieving such an effect. The second phase is aimed at bringing all that have been, unstuck together so that they can move together. And then the third phase is the evacuating, which actually moves all that have been collected towards the throat for expectoration. That is what the autogenic drainage is all about. But like I said, I apologize that I thought the video was on this system. My other system had a problem before the previous workshop. So I just got this other laptop, and I've not been able to copy all the things on my older hard disk to this new system. So I didn't realize that in good time, but I'll see what I can do subsequently. So this is the first phase, the unsticking. So it mobilizes secretion in the small airways at the bottom of the lung. And the technique is a big breath out, talking about the force. And with that, the force that the big breath is capable of generating, it unsticks the mucus from the wall of the airway. And then the collecting, you see, so this gathers the secretions and pushes them up the lungs into the main airways. So that's collecting. And then that, the technique there is a middle-sized breath in and out. So it's not yet trying to evacuate. It's like trying to gather it together before, moving them together. And then the third stage, which is evacuating, it pushes the secretion to the back of the throat, where it can then be coughed out. And again, that third phase requires a large volume of air. So you take in as much air as possible and then push it out. So this is talking about the actual procedure, which we will have seen demonstrated in the video. So this was where I will have embedded the video, but I couldn't, So that brings us to the end of the old techniques, the old chest physiotherapy techniques. So we'll move straight away to session 4, where we begin to look at the modern instrumented procedures. Yes. Modern instrumented techniques. The objectives for this particular session is that by the end of this session, participants will be able to understand the principles behind instrumented airway clearance techniques, be able to identify the different devices and how they function, describe the appropriate patient selection. In other words, which patient will a particular device be relevant to, the indications, and whatever precautions need to be taken in administering that device. And then we'll be able to perform personally, as well as supervise somebody else performing it in a safe and effective manner, the various devices. Now, to introduce these devices, we must first of all appreciate what necessitated their coming on board. There is this saying that you don't change a winning horse. If a horse continues to win, then you keep on using the horse because it's winning the medal for you. But when the horse stops winning and you are still interested in winning, then you go for a horse that can bring the medal to you. So we say that in situations and conditions of patients, when those old manual techniques become insufficient in terms of the recovery or improvement that we desire in a patient, or when a patient finds it difficult to tolerate those procedures, then the need for an alternative arises. This is what necessitated the development and introduction of the mechanical aids. And they have become so relevant and useful because of certain benefits that they have had to offer to patients. Number one is their consistency, because they are mechanical devices. So usage and reuse gives you consistent results. Unlike the old manual techniques that appear to be a bit subjective, and then there's the patient independence, in that a good number of those old manual techniques require the therapist carrying out those procedures for the patient. But for these new devices, portable and mobile versions of them have been developed such that patients can afford to have their personal copy and go home with it. And so the patient is able to continue that management or procedure even at home when he is not with his therapist. So that has brought the dimension of independence. And then it has also made it possible to access the deeper airway in terms of their effect, because a good number of them generate a kind of vibration that can be transmitted back into the lungs. And therefore, its effect can reach deeper into the lungs and the airway than the old traditional manual techniques. And of course, they have been put into categories. We have the positive expiratory pressure devices. In other words, usually the expiratory pressure is supposed to be negative because it's supposed to just be a recoil. But these devices are such that they make expiration to be active and therefore maintain a positive pressure in the airway even during expiration, to keep the alveoli open, to keep the airway expanded rather than collapsing. And the oscillatory versions of the devices, they are also positive expiratory pressure devices, but they have the added advantage that they produce some oscillation, vibratory effect. So they have the added effect of the positive pressure as well as the vibration or oscillation. Is a combined effect. Then we have the high frequency chest wall oscillation. Before, the old device was a handheld massager that you can place over the chest wall, over a towel, and then it will vibrate the chest. But that had been improved upon. So here now, it's designed as a vest. You know, those that are at construction sites or these traffic wardens, there's this vest that they can put on top of their shirts that usually have these reflective materials, either green, you know. When we went to school, we are not too familiar with many colors. What we knew that time was red, blue, black, white, yellow, and green. But now, blue has been broken into so many types. You talk about turquoise blue, sky blue, and all that, you know, whatever. So I don't know what color to call that green, but I think it will qualify as lemon green or so. I'm sure you know what I'm talking about. Those who work at construction sites or people who control traffic, and they put on this overall that have the reflective thing. Some, it can be maybe orange, then it can be that lemon green, but it will be reflective. That kind of vest, that's the way it has been designed. And so it is connected to a machine that transmits air into it in a vibratory manner. So that unlike placing the vibrator or the massager only on one surface of the chest at a time, the vest is one and it goes around the entire chest and it is vibrating the whole chest and thereby dislodging the mucus from the lining of the airway and thereby being more effective in unsticking the mucus. Then we have the mechanical insufflation, exsufflation, or the cough assist devices. So these are the four categories of these modern devices. And under each category, we have quite a number of devices. Remember, the oscillatory PEP, they are also PEP devices. It's just that they have the added advantage or benefit of oscillation or vibration. Now, talking about the positive expiratory pressure devices. Examples of these devices include the acapella, the paripep, and the therapep. And the mechanism by which they work is that they provide a kind of resistance against exhalation. So exhalation has to be forced to overcome that resistance. And by making the exhalation to become active, overcoming a provided resistance, the airway is kept patent, open, and prevented from collapsing. And so it makes it easy for the secretion to move on, even during exhalation. Unlike in situation where the airway tends tends to want to collapse or close up during exhalation. And by the time that narrowing has taken place, it will hinder the flow of the secretion. But in this case, the lumen of the airway is kept open so that flow can be easier. And we have clinical situations where this becomes useful. Like in chronic obstructive pulmonary diseases, we already know that it has an obstructive disorder. So anything that is going to make sure that the airway is kept open is going to help that patient. In cystic fibrosis, the same thing. Keeping the airway open is going to assist the patient. And of course, bronchiectasis. So, what do they do? You say it's a form of bronchial hygiene. And is one of the three adjuncts of positive airway pressure. Positive expiratory pressure, continuous positive airway pressure, and the EPAP, Now, the PEP involves active expiration instead of the natural passive expiration. And how is this resistance created? By incorporating a one-way valve into the device. And, the valve can be tightened, it can be loosened. And that becomes like when you have within an electric circuit a variable resistor. When you have a variable resistor or resistance in an electric circuit, the current that will flow in that circuit depends on how much resistance is incorporated. You remember the principle of the rheostat, variable resistance. So the higher the resistance, the lower the current if the voltage is constant. So the same way, to maintain flow, the expiratory muscles must now work hard to push the air against the resistance created by the valve. And that keeps the airway in an open situation. Now, the flow resistance can be manipulated, to adjust the desired pressure so that it can even be used as a form of training, whereby if a patient begins to work against a certain resistance, set on the device, initially it may prove difficult or challenging. With practice and with repetition, he gets accustomed to it and then begins to overcome that resistance much more easily. And then you can adjust that resistance by increasing it a bit so that the patient keeps on being challenged, and then the performance can improve over time. Now, the effect is believed to be dependent upon certain physiological and anatomical features in the lungs. In that, in the lungs, there are some collateral passages that through which air can flow, cross communications. We have the pores of Kohn, we have the canal or channel of Lambert. We also have the canal or channel of Martin. These are passageways for collateral flow that keeps, the airway open when positive pressure have to be generated. Is still talking about the procedure. We can use the postural drainage positions. It can be delivered through the face mask or mouthpiece, talking about the versatility and the flexibility of the application of the devices. Now, by virtue of this active expiration, there are certain precautions that must be taken. And there are certain situations where the therapists have to be cautious before embarking on this procedure for a patient. And we have a list of such situations here. If there's severe hemoptysis, some form of bleeding, facial fractures or surgery, which can get painful or uncomfortable with the effort that the patient has to make. If there is any ear problem or sinusitis because of transmitted vibrations. Now, talking about the various PEP devices, we have quite a number of them. And some of them incorporate the oscillation. And so sometimes they get treated separately as oscillatory PEP. Now, this is the acapella. We can see the image. We can see the models in terms of the flow. So, patient can be graduated from one to another. The issue of versatility, usage with the mask or with mouthpiece attachment. So let's see the device in use and the actual procedure.
This is only to be used following assessment and advice from your physiotherapist. The acapella is an airway clearance technique. It has two parts. Firstly, a resistance part with a resistance dial from 1 to 5. Secondly, vibratory plates inside that vibrate on the breath out. You can use this device inside lying or sitting up. Pass the a cappella to your patient, starting on a low resistance. Allow the patient to take a breath in through their nose and then breathe out through the a cappella. You can repeat the a cappella several cycles until the patient feels they need to cough and clear. If it is ineffective with a low resistance, then increase the resistance. If the patient then needs to cough and clear, allow them to do so. Otherwise, you might want to try it with a higher resistance. Allow the patient to keep repeating the technique until they feel they need to take a break. At that point, they may need to cough and clear, or they may need to return to doing some light breathing control.
Now, so we can see the dimension of training. We can see the dimension of patient improvement and the adaptation of the device with the improving patient situation. Another PEP device is the TheraPEP. But again, I don't have the video for that. Then the oscillatory PEP devices, we have the flutter. And the advantage is that it combines the vibration with the PEP effect, the positive expiratory pressure effect. It is portable, so the patient can carry it around. And it is patient-friendly. It's not difficult to use. There's the ease of use. And so patient can take it home and continue. And it will enhance a faster recovery from the patient because he's able to keep doing what you have demonstrated in the clinic. This is schematic diagram of the flutter. So we can see the area of the mouthpiece where the patient will exhale into the device, and then we can see the valve, and then that ball, which is a heavy ball. So the patient will have to blow with some good effort to lift this ball and allow the air to go through. That's the device. Again, the precautions, because it is also a positive expiratory pressure device. The same precautions that must be followed for the PEP devices must also be followed for the oscillatory PEP. So let's see the device in use.
This is a demonstration of the flutter. It's only to be used following assessment and advice from your physiotherapist. This is an airway clearance technique. Place the flutter into your patient's mouth. Take a long breath in through the nose and then breathe out into the device. You can do this in two ways. You can either tilt the device up or tilt it down. You'll find this will feel different in different areas of your lung, but find what's more comfortable for you to use and what's most effective in clearing your sputum. When you're doing it, ensure your cheeks are firm so you're channeling the vibrations of the flutter into your chest to loosen the secretion. Only repeat the flutter between 5 to 10 times and then have a rest. Either cough will clear or return to the breathing control.
Now, the next category is the high frequency chest wall oscillation that actually vibrates the entire thoracic cage. And the typical example is the vest system. And, you know, there's the inflatable vest that is worn, and it delivers the vibratory pressure to the thoracic cage. So the disadvantage of this is that it is a bit costly, and it's difficult for patients to have personal devices. Again, it is not portable like the acapella, like the flutter, like the cornet. So we can see the image of the vest with the machine that transmits the pressure, oscillatory pressure, through the tubings to the vest. This is an image of a patient that has put on the vest and is connected to the machine. So you can see how bogus the machine is. That makes it not to be portable. And of course, the cost makes it to be out of reach of individual patients. But it is effective. This is another model of the vest and design, but all of them work on the same principle. And you can see here that it specifically states that it is for use even in ICU patients.
Has already been pushing it forward to people who are coming in.
Sorry, somebody has not muted his microphone and is intruding into our class.
So that they will have a very good leadership.
Let that individual help us to mute his microphone. Okay, so now, like I was saying, you can see the indication for ICU patients specifically here, because it is appropriate. It does not require any effort of the patient, unlike the acapella, unlike the flutter. And yet, it delivers transmission to the chest wall to dislodge the secretion. So that when we now have case scenarios and you have maybe two patients having similar presentation in terms of problem, but one is in the ICU and maybe even in a state of altered consciousness, and the other one is maybe attending clinic on outpatient basis, or maybe he's even on a general ward and he's ambulant. And then you are talking about the device to use. For the one who is ambulant or who is on the general ward or who is coming as an outpatient or coming to the clinic on outpatient basis, you then know that the portable version will be most appropriate for such a patient rather than the one that is not portable. And then that patient can make effort. So you wouldn't need something that is passive for him, because in making active effort, voluntary effort, his performance is bound to improve and improve and improve. So you wouldn't want to bring him to the level of just doing something for him where he's not making any effort, and then he is losing the opportunity to improve in status. We can see another design of the vest here and the machine. So let's look at a demonstration. So it's a very short one. But, and the volume is actually low. The volume of the video itself is low from source.
Therapy vest actually comes with several components. Tubing which will attach to the vest organ. There are two connections on the back of the machine. One is for electrical power. Make sure you really see this plug. One of the most common problems that we find in the home. If you're ready to do therapy, turn on the power, you don't have it. Plug must be securely seated. The other connection is for your foot and hand control switch. It's important that you make sure that this is plugged into the control portion of these connectors, not the monitor. If you plug it into monitor, the vest will come on properly, but the switch, when depressed, will not start. Starting therapy is really quite simple. There's a single push-pull power button. And when you're ready to start therapy, you just push this blue button in. You'll hear a whine, and the yellow wait light will come on while the vest inflates. Make sure that you've set the frequency setting as ordered by the physician and the pressure setting as ordered by the physician. And those things will be taught to you at the initial setup time by the trainer.
So we can see how the air is being pumped into the vest and the vibratory effect that it is producing. And that vibration is transmitted to the whole of the thoracic cage.
Hoses will attach to the vest, and it doesn't make any difference which hose goes to which side of the vest, as well as the cross. In order to start the therapy, press the blue power button. Make sure that you've set the frequency and the pressure at the settings of the doctor's order. Yellow light will come on, which will let you know that the vest is inflating, and you'll be able to feel it inflate almost like a hug. And then once the yellow light has gone off, you can actually initiate the therapy by just squeezing on this micro control button. The vest will continue to oscillate as long as you keep the button pressed, but if you hold it down for more than 10 minutes, it will automatically shut off. During the course of therapy, you should stop about every 5 minutes and try to cough and clear your airway. If you're using nebulized medication, such as a bronchodilator or Pulmozyme, those two therapies can be combined to save time. Once again, be sure that the frequency is set properly, that the pressure is dialed into what the physician wanted. You can also use the timer so that you make sure that therapy for the prescribed time, which in most cases will be 15 to 20 minutes. And then just to press the hand and foot control switch, and your therapy will start. That you're going to be using all therapy rest files. What we'll do now is run through the setup.
So we move on to the cough assist, and that's the mechanical insufflation exsufflation device. And here, the mechanism is that it simulates natural cough for patients with neuromuscular disorders. Now we know that the cough requires, forced expiration, which requires muscular activity, muscular contraction. So where we have a patient that has muscle weakness, either because of a neuromuscular disease or even in a situation of deconditioning, and the cough has become ineffective, then even if you take that patient through all the other procedures that would dislodge the secretion, there is no sufficient force to cough and expectorate the secretion. So the mechanical insufflation exsufflation device comes in to simulate that cough. And so expectoration can be done of the mucus that is drained. That is the advantage of this device. And of course, you will therefore see that such a device will be useful even for patients that are in the ICU, including patients that are in altered state of consciousness. These are some images of the device itself. Then at the middle, top middle image here shows the various connections between the machine and the patient, together indicating that even a patient that is on a mechanical ventilator can benefit from this device. So you can see connection with a ventilator. That also tells us of the utility in the ICU setting. So let's see.
filter, corrugated tubing, connector, check adapter, or face mask. Open the machine and check the settings. Ensure that the settings are the same as the prescription. On the machine screen, you should see insufflation pressure, insufflation time, exsufflation pressure, exsufflation time, and pause time. Switch on the suction machine and cover the tip of the tubing with a finger. If you feel the suction pressure, it means that the machine is functioning. Adjust the pressure to 80 to 120 mmHg. Check for the patient's blood pressure, SpO2 levels, and heart rate before and after using the cough assist machine. Continue monitoring SpO2 levels and heart rate throughout the procedure. Attach the check adapter to the tube. Push the therapy or start button to start the session. Allow the full in-out cycle to complete. There are usually 4 to 6 cycles per set.
Can you
Monitor the face and lip color of the patient, SpO2 levels, heart rate, alertness, and tolerance level. Stop the therapy if the patient feels uncomfortable or if there is sufficient to be cleared. Also stop the therapy if you suspect that the patient is unstable. Push the standby button at the completion of the out time. You may refer to the bar as a guidance of therapy time. Disconnect the cough assist circuit and rest for 30 seconds. Continuous cough assist will lower carbon dioxide levels in the blood and lead to respiratory alkalosis. While the patient is resting, use the usual ventilation method. Perform suction if needed. Change the inner cannula to clear secretion. Repeat 4 to 6 sets as tolerated. The patient is not using a tracheostomy tube. Attach the cough assist tube to a face mask. Apply face mask covering the patient's nose and mouth firmly.
In, cough. Very good. One more round. Breathe in and cough.
For maintenance of cough assist machine, wipe down the machine with alcohol wipes or a damp cloth with mild detergent. Always keep the battery fully charged. Change the pollen filter when dirty. Change the bacteria filter once a month or when the color has changed. Clean accessories regularly to prevent infection. Wash track adapter and inner cannula with a brush. Ensure complete removal of all crusted secretion. Rinse with cool board water and air dry. Wash the face mask and corrugated tube with water and mild detergent. Rinse thoroughly and air dry. Do not use alcohol wipes to clean the mask as it will harden the surface. Change the cough assist tubing once a month. Cough assist machine.
So now, having looked at these various devices, we come to look at criteria to consider in selecting which device is appropriate for who and the clinical application of each of the devices. In considering the suitability of a device for a particular patient, factors to consider are listed here. The patient's age. Based on the age of the patient, the level of cognition that is required for the use of that device. Is it there? The amount of cooperation that is required by the patient in using that device, is this patient able to, cooperate to that extent? Then the diagnosis. Based on the diagnosis and the pathophysiology of that condition, the mechanism by which this device works, does it resolve the pathophysiology of the patient's condition? For example, the insufflator-exsufflator that is capable of simulating cough. You now have a patient that has a neuromuscular condition whereby the cough is ineffective. True, the patient needs airway clearance. You now select maybe the a cappella or the flutter because they are also useful for airway clearance. Now, on using the flutter or the a cappella, there is unsticking, there is dislodgement of the secretion. It has been mobilized. And it is now at the central airway where it should now be followed up with cough and expectoration. And there isn't sufficient muscular strength to carry out an effective cough. The secretion that is already mobilized and is there in the central airway can cause blockage in that larger portion, which means that a problem that would have been restricted to a small area, you have brought to a place where it can have a more widespread consequence. So you can see how the issue of the patient's diagnosis is important in arriving at which of the techniques or devices that will be appropriate. Then the coordination. Does the patient have sufficient ability to coordinate events? For example, look at the assisted cough. Assisted cough, where the patient needs to coordinate the movement with the respiratory cycle. Is the patient capable of such intricate coordination? Or if you ask him to carry it out, the whole sequence will be disjointed rather than being synchronous. Then the severity of the patient's condition. Can the patient cope with the procedure based on the severity? So we have here example indications for two of the devices that we have spoken about, like the flutter. The flutter is a positive expiratory pressure device that keeps the airway open even during expiration. So you can see how it can be useful in bronchiectasis and in cystic fibrosis, where there's likely to be decreased flow because of obstruction. Then the cough assist in spinal cord injury, where muscular strength to cough and expectorate is compromised, as well as in muscular dystrophy. So the device that is capable of simulating the cough is what is now being prescribed to assist or augment the effort of the neuromuscular system, or if that is so severe, to take its place. That is for the modern instrumented devices. So that has taken care of sessions 4 and 5. So I think we should just do session 6 before we have our lunch break, because the session 6 is interactive. And then after the interaction, we can go for lunch break and then come back for the final session, which is session 7, which talks about integration of this thing into our clinical practice.
So can we ask some questions?
Yes, please. Let's ask if we have questions.
Okay, sir. Thank you, sir.
Yes.
Thank you so far. Honestly, this is the peak of it, and I'm so happy I'm participating in this presentation. You're doing a good job, sir. I must testify that. So I have some questions. Okay,
yes.
Thanks, sir. I have some questions that I've drafted.
Okay.
One, can drainage, postural drainage and percussion and vibration, can they occur simultaneously? You said postural drainage can last for 10 to 15 minutes.
Okay.
Do you position the patient and wait patiently for the time to elapse before you start your vibrations, before you start your percussions, followed by vibration? That's number one, sir.
Okay.
Or do you do it simultaneously?
Okay. Yes, I get
Number
the question.
2. Okay, yes, sir. Number 2 question is, which of these techniques can be used in an intubated patient in ICU, an unconscious patient?
Yes.
These techniques that we have mentioned, most of the modern techniques. So,
yes.
I'm so much interested in an unconscious patient.
Yes.
Because there are a lot of challenges while managing them.
Yes.
An unconscious intubated patient. Which of the, I can see that most of the people you use, they are conscious. So the picture of unconscious patient has not come up yet.
Okay.
Okay. Okay. Number 3 question is: can both the modern and the traditional airway clearance be combined? Can it be combined at the same time as when you're managing your patient? You look at the two techniques and then you say, okay, let me go from here and combine in therapy.
Yeah.
Okay. Okay. Then my question again is HFCWO.
Yes, high frequency chest wall oscillation.
Yes. Can it be used in an intubated patient with ETT?
Okay. And the
ETT.
Yes.
Yes. ETT, like I have a patient with COPD,
okay,
who is intubated with ETT.
Yes.
And the man has been posing a lot of challenges. The moment we are struggling to wean him off. The moment the ETT is removed, is almost dying. He will be acting as if he's about to die.
Yeah.
So he has been put, and he has stayed a long time, more than a month, in ICU.
Yeah.
Okay. Okay, sir.
Okay.
So far, that's the questions I have. Thank you, sir.
Okay. Yes, let me start from the first one, but I'm going to leave out that third question for our session 7, where we are talking about integration, so that presentation will just answer the question rather than me trying to preempt what will be in session 7. So I will answer questions 1, 2, and 4. But to satisfy you in the first instance is that, yes, you are free to combine. But when we get to session 7, you will see this issue of integration. Okay. Now, talking about the postural drainage, the duration, and then those manual procedures. You don't have to wait until after that duration before you carry out the manual procedures. In fact, the manual procedures are components of that position. So it is while the patient is in that postural drainage position that you are carrying out your manual techniques. And as you carry out your manual techniques, the only interruption will be if the patient wants to cough and expectorate. That's when you give him the sputum mug, and then he expectorates into the sputum mug, and then he remains in that position. So during that period, your manual techniques will be ongoing. Is that okay?
Yes, sir. You know, the vibration, you gave duration of 3 to 5 minutes, 60 seconds, then 3 to 5 minutes, depending on the severity, depending on, So I was not thinking, but for the postural drainage itself should last for 10 minutes to 15. I was not thinking the vibrations keep repeating itself till the end of the position, to the end of each position.
Yes, you are free to have many rounds of the vibration and shaking within the period of postural drainage.
Postural drainage.
Yes.
And each position, is it each position that should be kept at 10 minutes, 10 to 15 minutes?
You know, even though we have several positions, the position you will use for your patient depends on which bronchopulmonary segment is affected. It's not that you are going to use so many positions.
Okay,
the X-ray or the MRI or the CT scan will have shown whether it is the posterior apical segment that is affected. So it is the position that is meant for that particular segment that you place the patient. And that's the position that is to be maintained for that length of time. And while that length of time is on, your manual technique is going on in rounds, and you are free to have as many rounds of your manual technique while the patient is in that position.
Oh, thank you, sir.
Yes.
I now understand.
Okay. Now, so the second question, that which of these things will be appropriate for an unconscious patient that is intubated?
Yes, sir.
Yes. It depends on what is that problem you want to address. But let's look at the mechanical insufflation and exsufflation that, you know,
I'm hearing you. I'm hearing you, sir. I'm hearing you, sir.
Because somebody didn't unmute and is interrupting. Okay, so let me continue. Now, you are talking about the kind of device that could fit into the situation of a patient in an altered state of consciousness and that is already intubated also. Then I now said that if you look at the image, let me go to that image straight away so that you can see what I'm saying. Session 4. Are you able to see the slide I'm showing now? Can you see my
slide? Yes, sir. Yes, sir. Yes, sir. I'm seeing it.
If you look at the images on the top row,
sir.
the one at the middle, you see the labels. Can you see my mouse moving over this one of them?
Sir. Yes, sir. I'm seeing it.
You can see ventilator.
Yes, sir.
And you can see the tube that is connected to the patient. That's intubation. That's an intubated patient.
Yes,
and
sir.
Apart from being connected to the ventilator, look at him connected also to the insufflator machine.
Okay.
So,
at the same time?
Yes, at the same time.
Okay.
Multiple connection. So it's possible. And then you discover that for the even for the other devices too, you saw that it could be administered through the tracheostomy tube. It could also be administered through face mask. So he's saying that where the patient is already intubated, you go through the tracheostomy tube.
Okay.
But where the patient is not intubated, you use the face mask.
Okay,
so,
sir.
Yes, so it depends on the patient's condition. Yes, so there are quite a number of devices that are suitable for the intubated patient in altered state of consciousness. Now coming to the one of the vest, the high frequency chest wall oscillation device, and this patient that is having a challenge with weaning from the ventilator. Now the vest is meant to dislodge the secretion so that it can be expectorated. So if it has to be used in a patient that is intubated and that is in an altered state of consciousness, it is not going to be a single therapy. Suction must follow, because as the vest would dislodge it, then since he is in an altered state of consciousness and he cannot be asked to cough to expectorate, the suction machine must be readily available to do either oropharyngeal suction or nasopharyngeal suction?
Okay, sir. I'm
Yes.
hearing.
So suction must join the vest in that patient. But that will just address the secretion. It won't address the issue of success in weaning off the ventilator.
Okay, sir.
Because the goal of the vest is airway clearance and
Okay,
not
sir.
necessarily related to weaning.
Okay, sir.
Yes. But I'm glad with these various questions because the essence of all these things is integration into practice.
Yes,
And
sir.
these are practice questions. These are practice
Yes.
questions. So
Yes,
it means that this workshop is already translational.
Yes,
The
sir.
knowledge is being translated to the bedside, and I feel
Yes, sir.
so excited.
No,
Well
the
done.
knowledge is quite translational, sir.
Yes.
The only limited challenges is not these machines, these gadgets, not is readily available.
Yes, yes, yes.
But when you have the knowledge, you can now be able to even make requests and know
Yes.
the right thing to request for.
Yes.
When you don't have the knowledge, you will not even know the right thing to request for.
That's very true.
Yes, sir.
Well done. God bless.
Thank you, sir.
Yeah. Any other question?
Good afternoon.
So you have not exhausted my question, no.
I said the third one. You know, you asked for. I've answered.
Okay, yes.
The third one, I said the short answer for now is that yes, it could be combined. But when we take session 7, which is on integration into practice, there's something I'm going to say there that will address this in a kind of comprehensive way. So I don't want to preempt that. So by the time I take that, then you will see the comprehensive answer to it. But the short answer to it is that, yes, we can combine both the old and the new.
Okay, sir.
Just like when we are treating malaria and we are talking about combination therapy. So
yes.
in airway clearance too, combination therapy is acceptable.
Yes.
The only thing is that whatever you are combining must be complementary.
Okay, thank you, sir.
Yeah. Okay. Yes. Any other question so that we can go into the interactive session 6?
Sir, please, I have a follow-up question to one of our questions.
Yes, please do. Ask your question.
Okay. What do you do in a situation where this ILIE device is not available? What can you do to assist an unconscious patient or a patient that does not have the neural capacity
sufficient
to produce
muscular strength to expectorate?
Yes, sir.
The suction machine comes in. Oropharyngeal or nasopharyngeal suction.
Also, sir, but the off and the cough is to assist to move the secretion from the lower airways to the upper airways so that the suction can help. But in an unconscious patient, how do you move the secretions from the lower airways, even after percussion, after vibration and shaking, up to the upper airways, to the trachea, so it can be suctioned out without this device?
Postural drainage. Positioning. Positioning will solve that. Postural drainage will solve it. You position so that gravity will drain it to the larger and central airway, and then you suction it out.
Oh, okay, sir. Thank you, sir.
Yeah, it's a pleasure.
Sorry, sir. Sorry,
No
sir.
problem. Yes. Ask your
Okay.
question.
Okay. Talking about postural drainage again,
Yes.
on a patient, an altered consciousness, in an altered consciousness of a patient.
Yes.
I'm worried about postural drainage.
Yeah.
In an unconscious patient.
Yes.
Because patient who is conscious.
Yes.
Will be able to express distress, express discomforts.
Yes.
You know, and then with that, you'll be able to know when to put a stop or not. But in an unconscious patient,
yes,
do you encourage postural drainage in an unconscious patient?
Yes, there's nothing wrong in running a postural drainage in an unconscious patient. You see, what will vary is what are the adjuncts, because postural drainage is just about positioning. In unconscious patient, we position them, we put them in various positions. So those positions are already suitable for postural drainage. And as long as the suction machine is there, in that once they are in that position, monitoring is the most important thing. That's why the ICU is a very sensory environment in terms of monitoring and things like that. And then even while you are there and you are carrying out any procedure, there are expressions of distress, even in patients that are unconscious. Even
yes.
some facial expression.
Yes, sir.
Aha. So all these are things you monitor and you watch out for, you look for as you are doing what you are doing.
Okay, sir.
Then when it comes to this category of patients, there's what we also call the modified postural drainage.
Okay.
Yes. So if by virtue of the patient's condition, there are some components of the comprehensive postural drainage that the patient may not be able to tolerate or that may not be suitable, you switch on to a modification whereby you only do the things that will ensure that the secretion is cleared, and any other thing that can cause any perturbation of the vital signs you avoid.
Okay, sir. Sir,
yes.
In a situation
so like
of
in that patient, you may not go ahead with all this clapping percussion.
Okay.
So you may not go into all that, but you position the patient so that gravity can do what it is able to do naturally, and then you suction.
Okay.
Yes.
Sir, in a case of a patient with reduced air entry.
Yes.
Reduced air entry.
Yeah.
And which of the techniques will be able to help to increase the level of air entry?
Yes. You see, when I teach problem-oriented approach to treatment and the identification of problems, I always say that there are problems that when they are written as a problem, you may not be able to solve it until you go further down. In that, when we say there's a reduced air entry, we must go further down as to what is the cause of that reduced air entry. Is it a weakness of muscles? Is it obstruction? Because if the decreased air entry is a function of obstruction, the solution is different from if the cause is muscle weakness. So the next thing is to go into what is the root cause of the reduced air entry. That's what will lead us to what will be appropriate to solve the problem. For example, let me give you another example that will illustrate what I'm saying. When we talk about patients with respiratory problems, we can talk about retention of secretion retention. Now, when we talk about secretion retention, it may be because the volume is larger than what the normal system can cope with. It may be because the secretion has become so hard and viscid that it is not easily movable. It may be because the cough reflex is weak and cannot expectorate it. And all of these three reasons, for example, will result in retention of secretion. But when we now say there is secretion retention, what will guide us as to the best way to deal with it will depend on our identifying which of these three possible reasons is actually responsible. Because if it is because the secretion is so thick that it is difficult to move, then the issue of humidification as well as administration of mucolytic will be the solution. If it is because of the weak cough reflex to expectorate, then the procedure of cough assist will be the solution. If it is because the volume is larger than what it can be taken care of, it is suction that will address it. So you can see the same problem, so to say, secretion retention, but look at three different solutions based on what is the cause of the retention. So the same thing, when we say there is reduced air entry, we must go further down to get to the root of what caused a reduction in air entry. That is when we will be able to deal squarely with the reduced air entry. Am I okay?
Thank you, sir. Yes, sir. Yes, sir. Thank you, sir.
It's a pleasure. Okay. So let me stop share and then let me bring up the session 6, which is meant to be interactive. If I open it ready. Oh, okay, so let me open it. Okay, so session 6 is clinical case-based application of what we have spoken about today. And the objective of this session is that our participant will be able to, one, understand how to create individualized chest physiotherapy plans. They will be able to integrate manual and instrumented techniques based on clinical evaluation. Then they will be able to analyze patient case scenarios to determine appropriate techniques. You know, analyze scenarios in order to determine which technique will be appropriate. So we are going to look at these three cases. And the task is that all of us, we are going to together suggest three things. Number one, what will be our goals of management? what protocol will we follow? And what precautions may be necessary as we are carrying out our procedure? Am I clear? Hello?
Yes, sir. Yes, sir.
So for each case, we are going to carry out these 3 tasks. So for the first patient, we will identify goals that we can set. We will identify what protocol to follow and what precautions may be necessary in carrying out what we want to do for the patient. When we finish with case number 1, we move on to case number 2. When we finish with case number 2, we move on to case number 3. So the first case is a 65-year-old man with chronic obstructive pulmonary disease exacerbation and retained secretions. So let's start with what will be our goals for such a patient. Let's keep on suggesting. We will suggest the goal and why we are talking about such a goal.
One of our goals should be airway clearance.
Okay, airway clearance. What
Yes.
made you to think that we need to clear the airway?
Because in COPD are excessive secretions.
Yes,
patient,
you are very correct, because it is already stated that there is retained secretions.
Yes, and the patient finds it difficult to expectorate.
Yes. So since there is retained secretion, there will be the need to clear the airway of that secretion. Okay. So
yes, sir. I also want to contribute. Since it's a COPD exacerbation, is it not possible there is an infection indicated here, so that we can take care of the infection first? Because what actually caused the exacerbation in the first place?
Yes, you are very correct, but we won't deal with that, because if there is infection, it is not within the purview of physiotherapy.
Yes, sir, I know that, definitely. But if we are just looking at the exacerbation and not looking at what actually caused it, are we really going to achieve anything with any of our technique that we are going to use? That's why I'm asking this.
It's a teamwork. Remember, healthcare is a teamwork. So this patient, we are not the only ones seeing him. So the medical team is also seeing him, and whatever is within their purview, they are handling it. They have only referred him to us to address the issues that are physiotherapy related. That's a multidisciplinary approach to care. So we only address the problems that are amenable to physiotherapy, because other problems that the patient has that are not amenable to physiotherapy, there is an expert, there's a specialist who is in charge of such and who is also doing his good job. Do you get my line of thought? And that's approach to multidisciplinary care. Okay.
Yes, sir.
I quite agree with you that there can be issue of infection, but we won't deal with it. We'll just leave that to the medical team. Yes, more contributions.
Yes, sir. We also need to open the airway.
Yes, because it says exacerbation of obstructive disorder, which means that there is going to be airway obstruction. So something must be done about the obstruction. But now, let's now look at that issue of the obstruction. You know, when we talk about obstruction, COPD is an obstructive disorder. Asthma is an obstructive disorder. But there is a difference between COPD and asthma. So approach is going to be different. So I'm provoking your lines of thought by that statement.
Okay, that.
So that nobody is bringing in any issue of bronchodilator here, because it's not asthma. Where we talk about reversibility. It is the definition of asthma that has spontaneous reversibility or as a result of bronchodilator administration, not COPD. You remember that we spoke about patient empowerment when we started. So we are going to go into some social history of this man. Is he a smoker? Did he go back to smoking habits? Which environment does he live in? Is there anything that could have triggered the obstruction by virtue of exposure, whereby there might be the need to isolate from such exposure? What about the others on this workshop now? I want to hear more voices.
Yeah, hello, sir.
Yes, sir.
Yeah, one other thing we can do is to promote the airway hygiene, because the secretions can be a site for infection. So one of the goals would be to promote airway hygiene there.
Yes, the airway clearance. Yes. One of our sisters mentioned that earlier on about airway clearance. Yes, definitely. So now, today we have looked at airway clearance techniques, both old school procedures as well as new school procedures. So let's talk about what protocol will you implement to address that airway hygiene or airway clearance. You remember that we are carrying out 3 tasks: goals, then we want to establish the protocol to use, and what necessary precautions, what precautions may be necessary. So which protocol are you going to suggest?
Good afternoon,
I will
sir.
suggest, okay.
Good afternoon, sir.
Yes, good afternoon.
Okay, sorry. I'm going to drag us back a little bit.
No
Under
problem.
the goals, sir,
yes,
I feel that some components of the patient's information needs to also be known, like an assessment of maybe the social history, the past medical history too, so that to guide our intervention for this kind of patients. Say if the person was having some other comorbidities, it will guide our protocol as to what intervention we are going to have. If the person has been a smoker, if the occupation is the type that exposes the patient to this type of exacerbations, it will now guide our protocols to say maybe we want to give patient education on.
Yes, that's why I spoke about
patient
empowerment, because you empower through education.
Yes, sir.
Yes, so yes, that's correct. You know, that's why I said you need to know whether he was a smoker. Was he tempted and he went back into smoking, or did he change residence recently, and is now domiciled where there is some kind of exposure? What is that exposure, and what type of isolation may be necessary from that exposure and whatever, those are some of the goals that, might have to be addressed. Yes. So protocol. There is COPD. One of the challenges is going to be increased work of breathing. There's going to be increased work of breathing. So part of your goal will be to reduce the work of breathing. So part of your assessment is perceived exertion, grade of perceived exertion, using either dyspnea, baseline dyspnea index or Bugs scale of perceived exertion. So you are going to need to set a goal to decrease the work of breathing. So when you want to do that, you are going to need a kind of breathing technique. So under that, your active cycle of breathing technique is going to be useful. So part of your protocol, active cycle of breathing is going to be there. Now there is obstruction, and your positive expiratory pressure devices assist in keeping the airway open even during expiration. And you know that in obstructive disorders, the obstruction, is more marked or pronounced during expiration and not inspiration. So the expiration phase, where the obstruction becomes prominent, you want to make sure that the airway is open during that phase. So your PEP devices must be part of your protocol. And then, of course, positioning, when you talk about the work of breathing, you don't even know this patient might be obese, whereby the abdominal content may be pressing against the diaphragm and therefore increasing the work of breathing. So upright position, where the abdominal content will fall down based on gravity, will be lowered, and then the diaphragm can be free to make its oscillatory movement, vertical oscillatory movement, depression of the dome during contraction, return of the dome during expiration, and things like that. So I've given us 3 of the protocols that must be followed based on this chest physiotherapy that we have learned today. Active cycle of breathing technique, PEP device, and upright positioning, device, which is an active device, an active cycle of breathing technique, which is a breathing technique.
Hello, sir.
Yes.
So I'm just analyzing. Thank you, sir. Thank you for all all the protocols that you help us to provide answer.
Yeah.
But I'm just analyzing the ETT intubated patient that I told you about.
Okay.
The active cycle of breathing.
Yeah.
I tried utilizing it, but because of the tube,
yeah,
he finds it difficult to take a deep breath in.
Definitely.
Yes, so he doesn't breathe in, and when he doesn't breathe in, the cycle cannot be completed.
Definitely.
And
because
again,
the ETT tube that is there, is it open or connected to a ventilator?
It's connected to a ventilator.
So if it is connected to a ventilator, we need to know which mode is the ventilator. Is he an assistant or a driver?
An assistant.
Yes, or a driver.
An assistant.
Okay, assistive mode.
Yes.
So if it is on an assistive mode, it is saying that the voluntary effort of the patient is inefficient or insufficient. So that's why the machine is assisting. So that patient cannot go through ACBT.
Okay. Okay. So what other protocol can I use to help this patient?
The thing is that they should gradually reduce the amount of assistance provided by the machine.
Okay.
That's when they can successfully win him off.
That was done. That has already been done. But when it was time to win him off, the patient was still not capable of breathing on his own. The problem was from peripheral hospital where he was intubated. He was intubated early.
Okay.
COPD, he was intubated early and in a private clinic, and he became dependent
on the machine.
On the machine.
Dependent.
Yes, became dependent on the machine. So just few seconds, if you remove, if he's extubated, he'll be breathless, panting for air. Oh, I've been struggling to.
What is is he on oxygen therapy?
Yes, sir.
They should check the dosage.
Okay.
The oxygen therapy dosage. So that if the oxygen therapy dosage is low, when they wean off, they can increase the oxygen dosage through the mask instead of the ventilator. Okay. And that will address the tissue oxygenation.
Okay. Okay. Okay, increase the oxygen therapy through the mask.
Yeah.
Okay. Okay.
In fact, another thing they could even do is they increase the oxygen therapy and they use the nasal cannula instead of the ventilator.
Okay. Okay, sir. So at this point, the physiotherapy intervention, that's my own major science. What can I actually, any other intervention I can do to assist, even when I'm advised on this?
Okay, in terms of physiotherapy management for the patient.
Yes, sir. Yes, sir.
Because this patient had been on the machine and has developed dependency on the machine and whatever.
And then I wanted to say something concerning that patient.
Yes.
Okay.
Good evening.
Yeah.
Okay,
Please.
I feel that patient is also having paralysis of the diaphragm. That is why the patient is also dependent on that. So there's something that I've done anyway when I went for my training. So there's this patient that anyway in a child, this patient was dependent on after he had surgery, was like dependent on ventilation. So we did what we called sprinting. So that sprinting is giving intervals. I remember you said, Ngozi, that even within seconds, the patient desaturates. So you're now looking at the saturation. And then is the patient's saturation decreasing? Or is it that the patient is not able to cope without ventilator? So there's a two-way thing now. So in sprinting, the patient is being taken off vents. and then you're timing it. So even if it's within 5 seconds that the patient can actually stay without ventilator, you mark that, and then patient is collected again, and then before you know it, and the diaphragm is taking up its action little by little.
Yeah, it's
So it's
be
called
like
sprinting.
training.
Training, yes, like training the diaphragm to work again. Because I feel now the diaphragm is paralyzed and also being dependent on ventilator. That could also work for that patient. Daily sprinting is a lot of work, but if you keep your mind to it, it will work.
Yes, but since the patient is not in an altered state of consciousness,
No,
I guess is
beautiful.
Conscious.
The patient is conscious, Abby.
Fully conscious, yes, sir.
The another thing is that when they in their weaning process, are they considering non-rebreather? Do you understand me?
Yes.
Are they considering like alternate non-rebreather? Because a non-rebreather will also give you a high FiO2. Do you understand me? Instead of weaning down straight to nasal cannula, they can see. Let's see if this patient can cope with non-rebreather face mask. At least 15 liters. You can give up to 15 liters per minute, and see how it works. While you retrain the diaphragm.
Yeah.
Okay.
And as a physiotherapist, you
Okay.
can within the window of when is not desaturating, you can do inspiratory muscle trainer.
Beautiful, beautiful. I wanted to say that now.
Yeah.
Inspiratory muscle
As
training.
minimal as the patient can do.
Yeah.
Okay.
Thank you so much.
Yeah.
Thank you. Thank you so much. My namesake, I appreciate.
Yes. So case number 2. Again, for this patient post-thoracic surgery with decreased chest expansion, what goals do we want to set? Which protocols can we employ? And what precautions may be necessary?
I'm saying my quota to be coming. Post-thoracic surgery pressure will decrease chest expansion. Chest. But the goal is to increase chest expansion, strengthen the respiratory muscles.
Okay.
Yes, sir. The inspiratory muscles, sir.
Okay.
Because that's when the chest expansion happens the most during inspiration.
Okay.
Then the diaphragm too. The diaphragm needs to be strengthened and activated.
The goal could also contain maybe.
I have a question.
Is he on this case?
Sorry.
Is he on this second patient or neutral?
No, this second patient regarding the goals.
Okay. Yes, please ask.
She said one of the goals is to increase chest expansion.
Okay.
This patient just underwent thoracic surgery.
Yeah.
So chest expansion at this point will be very painful. How do we do that?
Yes.
Or are we supposed to I feel like the goal shouldn't really be chest expansion at this point because the patient is still recovering. We should be talking about how to maintain ventilation with the diaphragm without full chest expansion until the patient recovers. I don't know. I'm just asking.
Diaphragmatic breathing.
Yes, sir.
Yeah. So what you have said has also brought out one of the things that must be addressed, the pain.
Yeah, the
Because
pain
pain
must.
management is within the purview of physiotherapy.
Yeah.
Then another thing is that there are some information you may still need to get. For example, what incision was used for the surgery? What was the route of entry? You know, take for example, you know that there are some thoracic surgery that they use sternotomy. Midline sternotomy, whereby they enter through the sternum anteriorly.
So standard precautions is also paramount here.
So that, yes, because that will guide you into some of the precautions that may become necessary. I hope we are familiar with instability of the sternum after surgery.
Yes.
Instability.
Yes, that's another thing I wanted to say. Yes, sir.
You know, so that all these things, you have to think about them and whatever. Therefore, you are going to have to identify necessary precautions as to not, disturb the fracture healing in the sternum. Okay? More?
Okay, so I think one of the goals here is to, you said decrease chest expansion. So it's obvious that this patient has reduced air entry or might be straining from pain. So one of the goals is to optimize analgesia and also improve air entry. And then in terms of the precautions, it's important to be able to rule out that this patient doesn't have pneumothorax from the surgery. So it's important you review the X-ray to be sure that the decreased chest expansion is not coming from either lung collapse, and also that the patient doesn't have any pneumothorax from the surgery.
Yes. So supposing part of the cause of the decreased chest expansion is atelectasis, what can you do? What will be part of your protocol? So anyway, the essence of this is to provoke thoughts. In various ramifications. And lung re-expansion will be necessary if there is any atelectasis. And in that instance, your incentive spirometry will come in. That will be part of your protocol in this patient. Okay, so
I also think PEP devices can work if you have ruled out pneumothorax.
Yes. If we rule out pneumothorax, which of those devices do you think will work? What will be necessary will be breathing techniques rather than the devices, because a good number of the devices, have to do with
resistance.
secretion. What this patient is having is decreased volume due to decreased chest expansion. So volume expansion is the major goal. and that is lung function test, spirometry, incentive spirometer, you know, to reopen whatever, improve chest excursion, paused lip breathing, diaphragmatic breathing, you know, those are the things that will be in that protocol. Then pain relief, and then splinting. You know, when you are taking patients like this through breathing exercises, they have to splint the surgical site using pillow.
Using pillows to support.
Yes.
Yeah.
So those are things that will come up in the protocol. And then the precaution will be to avoid anything that can destabilize, if it is sternal entrance, anything that can disturb sternal reunion or healing. Then, if it is not sternal, you want to know whether the sutures have been removed or not. If the sutures are still in situ, part of the precaution will be to avoid a disturbance of the suture. You know, those are some of the precautions that may become necessary. So because of our time, let's quickly look at the third goal. I mean, the third case. A child with cystic fibrosis. In cystic fibrosis, usually there is obstruction in the airway.
And there is mucus retention.
There's mucus retention because there is even a particular gene in cystic fibrosis that affects sodium absorption.
Chloride permeability.
Yes. So it affects sodium distribution, and that makes the secretion to be viscid in cystic fibrosis. So adequate hydration, humidification, and then to keep the airway
nebulization works
open.
so well with.
Pardon?
I said sometimes nebulization works for them.
Yes.
Yes,
Nebulization, you know, will work for dilatation, bronchodilation, and then your PEP device that will keep the airway open, and a device like the flutter or the acapella will be very useful because it looks like a toy that any child will like. So the child will just see it as a game to blow into an acapella or to blow into a flutter. You know, it will be age appropriate because as a child, they love toys. And the flutter and the acapella will be to him like a toy. You remember we said that part of what affects selection is age of the patient. It's like a good number of people just left few of us to be discussing.
That's what that's what I noticed.
They are turning it into Pareto principle, 20/80 rule. Okay. So we let me check what the time says now. I want to know whether I should just take the session 17 and then we close, or that we have a lunch break before we come back for that session 7. I don't know. Dr. Jibrin, what will you suggest? Let me check the time. It is already 7 minutes to 4. So,
sir, please, before we leave, we not talk about the precautions of the child with cystic fibrosis.
yes, in terms of precautions for that age, there is none of the devices or the protocol that we have suggested where there is any possible harm. So we might not be able to identify any precaution immediately.
Okay, sir, but for the child with cystic fibrosis, the vest,
Yes.
the HFCWO vest,
Yes.
will it be beneficial for the child?
When you look at the fact that that is expensive and it is not mobile, it is not portable, it won't be the choice of device, because we have smaller devices that will do the same thing that the vest is going to do, in terms of the acapella or the flutter. So that it won't appear that we are trying to use a bulldozer to kill the cockroach.
Okay, thank you.
Yes.
Then, so I think a precaution would be, or one precaution with, for the third case.
Yes.
I think one precaution would be the fact that if there are some parts of these devices that are losable or immovable, it should be, the child should be monitored so that they don't ingest or swallow it by mistake during the process.
No, the acapella and the flutter, they are quite sizable. They are not tiny objects that can be swallowed.
All right, sir.
Okay. Yes, sir.
Yes.
I'm sorry to take us back. The
no
second
problem.
case,
It's interactive.
yes, sir. The second case, would it be also appropriate to incorporate neurophysiological facility of respiration, maybe like intercostal stretch to improve chest expansion? Looking at the post-thoracic, I don't know if it's going to be appropriate for the kind of patients.
Because of the injury, the trauma of the surgery, you will not want to involve any muscle here. In fact, presently, there is likely to be what we call muscle guarding because of pain. There's likely to be muscle guarding.
Hello, sir.
Yes.
Okay. So sorry, please, I still want to take us back a little.
No problem. It's interactive.
Okay, sir. So
That's the beauty of interactive session.
Okay, sir. Sir, you mentioned the atelectasis.
Yes, atelectasis. Yes.
There's this case that I'm handling presently.
Yes.
I introduced the aesthetic spirometry, but I found out that the patient is finding very, very difficult to utilize it. Whenever she starts using the aesthetic spirometer, the patient will develop pain. As in she's
what?
Pain. She will start complaining of pain that at a point.
What's his primary diagnosis?
Atelectasis.
What resulted in atelectasis?
Okay. Okay. One, the patient she's allergic. She has this allergy, and then
allergy. Okay.
Yes, and then She was diagnosed of infection.
Okay.
A lung infection.
Okay.
Aspergillus.
Okay.
I can't remember exactly the name.
Aspergillus aureus.
Thank you, sir. So, but the patient, has been managed and confirmed free, but the pain and once she start using the incentive spirometer, before you know it, she become breathless.
Okay.
And once the pain starts,
which type of incentive spirometer was prescribed for her? When we talk about the incentive spirometer, there are two types. There's the inspiratory, there's the expiratory.
Is the inspiratory.
Okay.
It's the inspiratory that is prescribed. He has to take a deep breath. He has to breathe in, not sucking the air.
Yes, they should change to expiratory for him. Expiratory is incentive spirometer. Is often easier than the inspiratory. Expiratory, yes, where he's blowing out. And the good thing about expiratory incentive spirometer is that you can even try it on yourself. If you blow air out and you prolong it such that you empty the air in your lungs very well,
yes, sir.
The next inspiration is going to be very deep.
Okay.
You can try it even now. You try to blow air out as if you are blowing out a candle, and you keep it for long. Check the kind of inspiration that is going to follow.
Oh, I've tried this. It's deep.
Very,
very deep. Yes.
So that immediately you give the expiratory. Now he is going to find it fun. When it is inspiratory, he has to make a lot of effort. And it will strain him or her. But expiratory, you just blow. And once you blow whatever, the next inspiration is going to be deep. And he won't even have to think about it. It will just occur naturally.
Oh. Please, I have to go and source. I don't know where. I've never seen expiratory. It's only expiratory. It's only expiratory that I've come across. Okay.
Yeah.
Maybe I have to go and I will ask for. I will recommend that for the patient. Thank you so much, sir.
It's a pleasure.
Good afternoon, sir. Please, I have another question.
Please ask.
For the patient with post-thoracic surgery,
yes,
with decreased expansion, you mentioned instability of the sternum after surgery.
Provided it is a mid-sternal incision.
Yes.
There are so many points of entry into the thoracic cage.
Okay.
It could be mid-sternal, it could be parasternal, it could be subcostal, and so many points of entry into the thoracic cage.
Okay.
But I've just brought that out based on especially the issue of the question on precautions, so that where there's a mid-sternal thing, one of the challenges of that procedure is instability. And so with instability, a lot of precaution is required. That's why I deliberately mentioned that.
Yes. No, what I wanted to ask, actually, because you talked about splinting using pillows. When a patient has had this surgery, and let's say the patient wants to cough.
Yes.
And I know that when you have a surgery, normally when you want to cough, it becomes painful or hard. And coughing may cause, I don't know, might mobilize the part that you want to immobilize.
Yes.
You understand the question I'm asking? So how do you, as a physiotherapist, teach your patient how to cough without causing harm to that particular place that there was surgery, or to the surgical site?
By using pillow splint. You place a pillow and hold it tightly to that place and cough. So the pillow will splint the place. That's
Okay.
splinting.
Okay.
Yes.
Thank you.
You can use pillow, you can use towel, folded towel.
Okay. Thank you, sir.
A pleasure. So considering the fact that it's already about 4 o'clock now, maybe I should just try and bring up the session 7 and see how I can fast track it, and then we just close. Instead of having a break when people may just get distracted. Dr. Jibrin, what do you think?
He's not around, sir, so you can just continue.
I can see Ray Institute being represented. Who
Yes,
is
sir.
behind the device? You know, the person can speak for the institute.
I'm not the artist.
Okay. So what do you suggest? I'm thinking that we should just take that last one and see how we can make it short and then close. Instead of going on any lunch break again now. It's already 4 o'clock.
Yes, sir. You can take it so that you can close all at the time.
Okay. Thank you very much. Okay. So are you able to see my screen now? Can you see my screen?
Yes, sir.
Yes.
sir.
So the last and final session 7, integration and documentation. So again, the objective for this particular session is that by the end of this session, participants will be able to understand how to create individualized chest physiotherapy plans. We'll be able to integrate manual and instrumented techniques based on clinical evaluation. They'll be able to apply protocols for different clinical settings, whether ICU setting, ward setting, or home-based setting, home-based care. They'll be able to analyze patient case scenarios to determine appropriate techniques. And that's part of why we had to go through that case-based interactive session in session 6. So talking about clinical integration, we discover that in any caseload management, there's the need to undertake patient-centered planning. Because it is when we take patient-centered planning that whatever plan we have will make a meaning to the patient. Our management, our intervention must be patient-centered. I love to use this illustration. Imagine an Islamic leader who leads prayers in the mosque. And you know, a leader, a religious leader, sees his position and his responsibility as a privilege. He sees his assignment as God giving him a privilege to serve him. And so no spiritual leader, no religious leader wants to take the discharge of his responsibility lightly at all. Many even appreciate the fact that it is when they are faithful in discharging their religious responsibility that they continue to enjoy God's blessing. So with such an understanding now, a religious leader in the Islamic setting who leads prayer in the mosque now has a problem with the low back. And there is, you know, a lot of limitation in range of motion at various joints, including the back. And he's now referred for physiotherapy. And then the physiotherapist did assessment and measured range of motion. And he discovered that there is limitation in several places and now wants to set his goal and begins to state his goals and say to increase the range of motion in the hip joint from X to Y in the next 2 weeks, to increase the lumbar flexion from A to B in the next 2 weeks, and is writing about such whatever. In terms of academic work exercise, that's not wrong. But this man who is a leader in the mosque, this limitation is affecting him and disturbing him from making the necessary prayer moves. You know, there are postures that they have to keep when they are leading prayer. Bow, sit, squat, and, you know, all manner of prayer movements. The problem is hindering him from carrying out those movements. And then the physiotherapist is writing statement of goals and he's saying to increase range of motion from X to Y. Would that make any meaning to that man? What will make a meaning to that man is to do a functional assessment and say, okay, this man is not able to genuflex, is not able to squat, is not able to bend to lead this, or able to maintain this prayer posture. And then in setting the goal, he now sets the goal and he say, Alaji ABC shall be able to resume his duty as prayer leader in the mosque in the next 3 weeks. Now, imagine how that statement of goal will make a meaning to this man. compared to saying that you will increase range of motion from A to B, from X to Y in the next 2 weeks? Which one do you think will make a meaning to him? Hello?
Sir, sir, can you come again? I didn't understand the question.
I was saying you have a prayer leader in the mosque.
Okay, sir.
You had problem with the back.
Okay, sir.
And it is affecting him from leading prayer in the mosque.
Okay, sir.
And he's referred for physiotherapy. And the physiotherapist in setting goals is busy writing statement of goal to increase range of motion in the right hip joint from A to B, to increase the range of motion in the left hip from X to Y, to increase lumbar flexion from P to Q, and whatever. And then I said, compare that to another physiotherapist who, instead of measuring range of motion, did functional assessment and says Alhaji ABCD is currently not able to genuflex, cannot bend and carry out the prayer movement in the mosque, unable to squat. And then he now say goal. Alhaji ABCD will be able to resume his duty as prayer leader and lead prayer in the mosque in the next 3 weeks. Which of these statements of goals will make sense or meaning to the man?
The second one. The second PT, who is goal-oriented.
The second PT, sir, who is focused on the functional, in the functional abilities of the patient, or the functional goals of the patient.
Hello, sir.
Are we still
Hello,
there?
can you hear me, sir?
Yes, we are with you, sir.
Yes, sir.
You, sir.
Are
Can
we
you hear
still
us, sir?
there?
Yes, sir. We
Yes,
can
sir.
hear
We
you.
are together, sir.
We're hearing you.
Okay, I think it's my speaker that is not making me hear you. Yes, please speak.
So the second PT, who assess the functional capability of the patient and is goal-oriented.
Sorry, let me adjust my speaker. Okay, please speak. Let me see. I think I should just hear from the system directly now.
Yes, sir. We are with you.
So I said, which of these statements of goal will make sense or meaning to the man?
That most of us say the second PT assessment.
Yes, so that in our practice, there's the need for us to be patient-centered, to focus on things that will be relevant to the patient. So, based on that, and the need to balance effectiveness of our intervention, to balance the issue of tolerance and equipment availability, there's the need to integrate these things into practice. So our chest physiotherapy protocol, there are certain assessment parameters that are necessary so that when we assess them and we identify challenges in those areas and we set our goals to address such identified challenges, it will make meaning to the patient. So our assessment parameters in arriving at chest physiotherapy protocol should include chest expansion, auscultation finding, sputum characteristics, the arterial blood gases, the vital signs, and the tolerance to interventions. And when we now want to talk about protocol, the protocol we set out must have certain components. Number one, it must have frequency. How frequently must the thing be carried out? No physician will prescribe paracetamol without telling the patient how many times in a day he should take it. Part of the important components, let me see whether this speaker behave, is timing in terms of when exactly to carry out what needs to be carried out. For example, there are medications that are prescribed, and they say you should take it after your meal. That's timing. So likewise, in our chest physiotherapy protocol, timing will be very, very important. Take, for example, a patient, maybe an asthmatic patient, and you want to take him through some exercise protocol. It will be good if you time the performance of those activities to shortly after he has just taken his bronchodilator. Shortly after taking the bronchodilator, the airways will be open, will be dilated. So he will be able to breathe freely and take in oxygen to take care of the activity you are subjecting him to. Another important component of the protocol, when we write out our protocol, is positioning. In the various videos that we watched, you saw how important the issue of positioning was in carrying them out. It was specified. This in sitting, this in lying position. And then another component, which I told my sister that during this session, I'm going to expand on, is combination of techniques. I hope she's hearing me now.
Yes, sir. So I'm hearing you. I'm with you.
Hello, are you there?
Yes, sir.
Can you hear me now? So your question that I said
you.
I was going to defer. So you can see it clearly on my slide here.
Yes, sir. Yes, sir.
So that there is nothing that says that you are to use only one technique in managing a patient. You can combine techniques. You can combine 2 or 3 instrumented techniques or devices. You can combine 2 or 3 old chest physiotherapy protocols. You can combine from among the old and the new, as long as the various techniques you are combining are complementary in effect. That's the only important thing. Now, we come to integration by setting. In other words, we need to integrate all these things to our practice in various settings. So you can see in ICU and high dependency units, to integrate these devices and protocols in the ICU setting, all we need to do is to prioritize safety and minimal handling in the first instance. We prioritize safety. Safety is important. And then we minimize handling. And various interventions that are useful and relevant in the ICU setting include suctioning, positioning, early mobilization, and adjuncts like positive expiratory pressure devices. For medical wards, in other words, other wards apart from ICU that are not high dependency locations, we can combine manual techniques and breathing exercises in managing patients. But we must monitor certain things so that our management can be outcome-based. We must monitor sputum volume. We don't say because it is just the medical ward, monitoring is not too important, unlike ICU. We must monitor. We must monitor oxygen needs of the patient, and we must monitor fatigue report. For outpatient and home-based care, the emphasis should be on patient independence and patient education. Patient independence in the fact that he can carry out some of those things by himself without having to depend on somebody else to take him through it. So we lay emphasis on that. And when the patient is able to help himself seriously, recovery will be rapid. Improvement will be substantial. We must also lay emphasis on patient education. That's empowerment. And various interventions that are relevant in outpatient and home-based care include various devices, like all these PEP devices that are portable, and the patients can afford to have personal copies. You know, they are relevant for home-based care. Then exercise adherence, and a good number of times is a function of patient education. Because if the patients don't understand why it is important for them to do it, they might not adhere. And then regular reviews to monitor progress. Thank you very much for your patience and your listening ears.
Thank you so much, sir. Thank We're you. grateful. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank God.
And for your
Thank you, sir.
patience. And for your patience. You're very patient.
And
Good
well
afternoon, sir. Thank you
loaded.
for
Thank
sir,
God.
please, I have a question.
Yes, please. Go ahead with your question.
I have a colleague that was telling me about a polytrauma patient who had rib fractures and flail segments, and the patient also had pneumothorax. But on MDT meeting and everything, they said that they do not need to stabilize the flail chest because it would stabilize itself. So there was no need for any immobility or any type of surgery or anything. And my question is, that patient already had pneumothorax, probably because of a lung puncture from one of the segments. So how would we go through rehabilitating that patient since they already said there was no need to stabilize any of the flail segments?
Okay. Are you saying the lung segments did what?
No, sir, the rib segments. So the person had
Okay,
rib
the ribs.
fractures.
Okay,
The
chest is flail.
Yes, sir.
Okay, flail
And the
chest.
person also has a pneumothorax too.
Okay. Now, actually, in polytraumatized patients, especially if there are, like rib fractures and things like that, one thing with the thoracic cage is that the bones that are there, they are closely padded with flesh. And so the challenges that we have with axial skeleton, like the bones in the upper extremity and lower extremity, whereby there can be displacement and whatever, is minimal around the thoracic cage because of the padding by muscles, the intercostal muscles. So if there is no penetrating wound, they would rather leave the ribs like that, because any attempt to want to deal with that is going to require surgery. They are going to look at the current situation of the patient. You just said that the patient already had pneumothorax. So a patient with pneumothorax already, to now begin to go in and do surgery will be adding more to his trauma. And so they will have to look at the benefit. There's a ratio I want to talk about. Risk-benefit ratio, in terms of, okay, what are the chances of improvement? What are the chances of adverse event? So if they realize that even the amount of benefit we will get if we put him through this surgery, it's not going to be worth all the trouble he's going to go through. They would rather leave him. More so that whatever those challenges are not life-threatening. So I believe that is why they are saying they don't want to do any surgery or whatever. But in that patient, what should be done should just be problem-oriented approach. What are the presenting problems? If it is decreased ventilation, how can we improve ventilation, even with its present circumstances? If it is decreased exercise tolerance, to what extent can we improve his exercise tolerance within what his capacity is presently? That should just be the approach. They might have analyzed and seen that the amount of benefit they will get from any surgery is not worth the trouble you might be put into.
Okay, sir. Thank you, sir.
Yes.
Sir, I have another question.
Yes, please.
I have a patient with chronic lumbar spondylosis. So she started having back pain when she was pregnant.
Okay.
Then after giving birth, pain reduced. She started coming for physiotherapy even when she was pregnant for pain, which we managed.
Okay.
Then about 2 months after delivery, the pain came back.
Okay.
So, but in addition to having pain, she started having very sharp pain in her back around T6, T7, like around the scapular area there. But that pain only happens when she takes a deep breath.
Yeah.
So if she's not breathing deeply, there's no pain there. But once she tries to take a deep breath, not even very deep, but like normal breath, she has sharp pain in that region. So now she takes very shallow breaths because she wants to avoid the pain there. And she's breathless. She's not able to exert herself as much as she would. So I'm not sure exactly what the problem was because we sent her for tests and to the orthopedic doctor also, and they found nothing. But she still had that
Did they
pain
do
when
an
she
X-ray?
breathed. Yes, sir. They did.
Is there any structural abnormality or postural deformity?
No, sir, there isn't.
Because there can be it might not be structural, it might just be postural, and there is a kind of nerve impingement.
Okay.
From the narration now, I'm suspecting nerve impingement.
Okay, sir. But she said when she tries to compensate and like bend forward and takes in deep breaths, there's no problem. But if she's standing up straight or sitting up straight,
that's why I'm suspecting nerve impingement. So the solution most likely doesn't lie with the orthopedic surgeon, it lies with physiotherapy, whereby what is necessary is postural correction. You know, we try to see, just like when you talk about this peripheralization and centralization of pain, you do movement tests to find out what movement will cause peripheralization, what movement will cause centralization, what movement aggravates the pain, what movement relieves the pain. So if we know the movement or the posture that relieves the pain, we try to look at the reverse direction. Is there any nerve that could possibly be impinged upon by a reversal of the posture that relieves our pain? If there is, then that is where to handle. And mere Hungarian technique might just solve the problem. Either vertical oscillatory pressure or transverse oscillatory pressure, VOP or TOP, may just be the solution to our problem.
Okay, sir. Thank you, sir.
Yeah. So, in the absence of any other question, I want to say good evening to everybody. Enjoy the rest of the weekend and keep on developing yourself professionally. The sky will not even be your limit, but your launching pad. And once again, to the organizers, I want to say a very big thank you for giving me the opportunity to share my knowledge with others. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, sir.
Quite impactful and interactive.
Meet some other time.
Well loaded.
Thank you. God bless you, sir.
Amen.
Thank you so much.
Thank you.
Thank you.
Thank you, sir.
All right. Good night, sir.
Good night.
Thank you so much, sir. Wow.
We thank
It's been
God.
an awesome journey. I really learned a lot. Thank you. Thank
We
you so
thank
much.
God.
Amen.
Thank God.
Thank you, Reverend Sir.
We thank God.
We
Is
really
that
learned
good,
a lot.
brother?
Yes, sir. Nami, sir. I'm the one.
You are blessed.
Thank you, sir.
Amen. Thank you, sir.
Okay.
Thank you, sir.
We thank God. Okay.
Thanks. Thank you, sir.
Oh, we thank God.